have Tonicclonic, the one we are popularly familiar with, grand mal fit, a tonic-clonic. Absence, the petit mal. Have other forms, tonic, tonic, atonic, and myoclonic. And then occasionally for epilepsy proper, these are seizure classifications. Occasionally, in order to have a categorization that is useful, the clinician in epilepsy, they are also able to classify epilepsy itself into syndromes. So you have a child, for example, showing epilepsy. It's not just going to be one type of seizure the child would show. Occasionally you have tonic-clonic mixed with absent seizures. Okay, so they have categorized the pattern of seizures, the age of onset, the things that trigger it, the way the abnormality looks like on an EEG. They have put all that together, create classes or syndromes. Okay? So there are a number of them. There is one called juvenile myoclonic epilepsy. The characteristics are there. So you can diagnose that as a type of epilepsy patient. And that can help to choose the right drug for the patient. So that is not here. These are just the epileptic seizure classifications, the type of seizures that you can find. So I want to show you some videos of some of them. Just to give you an idea so that when you spot these things in the clinic, you can have an idea what is going on. So I will start with the focal seizure without its cognitive features, the old system that is called simple partial seizure. Just an area of the brain, not the whole brain, one hemisphere. And as Dr. Donet said, the part of the brain where the seizure focuses determines the symptoms. There are various areas that control different aspects of our physiology. So depending on where the focus is, because that area of the brain is responsible for particular physiological function, see the symptoms as an excessive manifestation of the role of that area of the brain. For example, as I mentioned earlier, we have the motor cortex. You have a group of neurons somewhere around here, the cortex, which are responsible for crude muscle contractions. If the seizure focus is on your motor cortex, what do you think will happen? You have muscle twitches. That will be the manifestation. So a seizure that involves the motor cortex producing muscle twitches as a manifestation is what is called a convulsion. So a convulsion is a subset of the bigger picture of seizures. Seizure is describing the electrical disturbance. But if the electrical disturbance leads to muscle contraction manifestations, then you call that a convulsion. Okay? So convulsions are seizures, but not all seizures are convulsions. You cannot always see a seizure's manifestation as muscle twitch. I will show you a few examples. In absence, there is no muscle twitch. In complex partial seizure, you might not find any muscle twitch. If it's the temporal lobe that is affected, it's just behavioral changes that you see. Like Dr. Donet was saying, there was a case in class when the seizure occurs in the child will rise, walk around the classroom, maybe insult somebody or beat somebody. Within a few minutes, will come and sit down. Okay? And then the seizure is over. The student doesn't recollect anything that has happened. Whilst that seizure was going on, whilst he or she was moving around and all, they don't remember because consciousness or awareness was impaired. Okay? So, so the point I'm making is that seizures will not always manifest as muscle contractions. And occasionally, if the focus, for example, is in the hypothalamus, there can be a dysfunction in the hypothalamus. So your symptom is going to be excessive autonomic discharge. You are there, and then all of a sudden you start sweating, you have palpitations, your BP goes up, you have cholinergic discharges and all that. It can just be a seizure occurring briefly with the focus in the hypothalamus, which regulates the autonomic system. Okay? So that would be a hypothalamic seizure, for example. Now,
I have a question.
let me make this last point, then you can come in. The, in the temporal lobe, when you divide the temporal lobe in two, you get to the hippocampus that we were talking about. The amygdala is also there. If there is a discharge in the amygdala, you expect that your symptoms will include intense fear, because the job of the amygdala is fear processing. Okay? If the hippocampus is affected, you can be forced to experience some old memories. You are there and then you remember some memories are being forced on your mind. Not all of a sudden you are remembering some things. Okay, it can just be a disturbance in the hippocampus, which is responsible for explicit memory storage and recovery. Occasionally, for temporal lobe issues too, the person may experience deja vus. Okay, you are there, and all of a sudden, things appear familiar. Oh, it appears I have been in this lecture before. You have that feeling, or the opposite, jamais vu. All of a sudden, the whole place is strange, as if you have never been here before. You don't think this place even exists. It's as if you are appearing here for the first time, even though you've been here for this is the third day. Okay? So the manifestations of a seizure depends on where the abnormality is. If it affects the motor cortex, then you have convulsions. Okay. So I want to show you, let me show you the videos. Then after that, you can ask the questions, after which we look at the drugs. So we'll start with simple partial seizure. So this is, I've taken this from someone's presentation. So you look at this screen. So you see that the right leg is having issues, which means that on the left side of his brain, the area in the motor cortex that controls the legs is having an abnormality. Okay? Because for motor function and a few other things, the right side of the brain controls the left side of the body and vice versa. So there is a simple case, focal seizure without any impairment of consciousness. So it's just a twitch that you have. So that is a convulsion, okay, because you see the flex, the legs there. Then this is a focal seizure with these cognitive features. Awareness is impaired. Okay, so whilst the seizure is going on, the individual is unaware of what is happening in the surroundings until the seizure is over, before that awareness returns. Okay? In the old system, as I said, it was called the complex partial seizure. So this guy is having a complex partial seizure. So he is not aware of what is happening around him. He is confused. He's experiencing some funny sensations during this period. Now, there is even a little motor action here. Look at the right arm. Okay? So, having issues there. Wife will come around, mention his name. He's not aware of what is happening. Are you okay? He doesn't recognize that the wife is around, because awareness has been affected. Now, in other manifestations, you have what are called automatisms. The person repeats some particular behaviors throughout the seizure period. It may be combing the hair, the person may be dressing up throughout this. Something repeats, then it will stop when the seizure is over. So the one that we are most familiar with, the tonic-clonic. And before you watch, let me just explain briefly. This is tonic-clonic because there are two phases. It starts by all the muscles in the person's body contracting. The person will be in a state of contracture. Okay? Medically, they call it opistotonus. All the muscles will contract. Then the person will fall down. This will happen for about a minute, about 2 minutes. Then the second phase, the clonic phase, where the muscles contract and relax. So you see shaking, that is clonic. Okay? You watch it. Don't know why he decides to play. He has epilepsy and he's interested in this sport. But I mean, that is his pleasure. So he starts, and then the seizure is triggered. So he starts. So you see the tonic phase first. All the muscles contract. Okay? And then the second phase, the clonic, where you see the shaking movement. So as this is happening, see some autonomic features. There will be foams coming out of the mouth. There will be incontinence, urination, defecation. All those things will happen during the period. And so it's very disturbing, isn't it? Yeah. So this is the typical tonic-clonic seizure. Okay? So when the seizure is happening, there is nothing you can do about it. Unfortunately, the evidence is that it doesn't significantly affect the brain function. So just allow the seizure to occur, but initiate therapy to prevent it from happening. So that's the goal of epilepsy. You give the drug, prevent this from happening. You are unable to interrupt it because the period is short. By the time your drug gets into the system, the person has recovered. There is no need trying to interrupt. And you don't also put anything in the person's mouth, like the old women do in the villages. Okay? It is dangerous. It can lead to aspiration of whatever you are putting in there, choke the air. Is very dangerous. So just move the person away from danger by some gutter or the roadside fire. Move them quietly. Hopefully by 4 minutes, stop. Then you can take them for examination and then maybe treatment can be started. Um, it doesn't really matter. It is better for them to bite their tongue than you putting something there that will choke them to death. Okay, so that is the recommendation. Now, absence. Absence is very common in children. Okay, very common in children. And what is happening is that there is a brief pause in consciousness. So the child becomes absent for a while from consciousness, a few seconds, and then returns. And after the consciousness comes, you don't see any disturbance. Whatever the child was doing before, they will just continue doing. You are making a sentence, Kofi is. Pause. When the consciousness comes, the rest of the statement continues. Okay. Right. So, um, so this boy has absence epilepsy. So he's writing, and so all of a sudden a seizure would start. So once you see blinking, uh, the child blinking, you know that the seizure has started. The seizure is occurring. He's unaware of what is happening around him until, yes, consciousness is back. So he will continue what he's doing until another one comes. Another one. Okay. So this is it. And the challenge is that in school, a teacher might just think the child is not paying attention and start caning him or her. Okay, so we need education on some of these things. I have another one here, but you can look at it later. Then a focal seizure that generalizes into um, that generalizes from the focal status. What was called partial seizure with secondary generalization. So the guy we saw at the beginning with the complex partial seizure, we are going to see his complex partial seizure degenerating generalized one. So the complex partial seizure has started here. So you see that confused. Then it has generalized now. So this is the tonic-clonic feature. This is the tonic phase. You see all the muscles are contracted, including the oral muscles. The mouth is okay. So tonic. As soon as you see jerking, it means the clonic phase has started. Clonic is coming in gradually. Started it. This one, if you don't take care, he will fall off dead. So check him. Right. Then after about 2 minutes to stop. If it doesn't stop, then it has assumed a status epileptic. Okay. Then that one you have to intervene, stop it with drugs. Atonic, a very interesting one. Atonic or akinetic. When the seizure happens, the individual loses muscle tone. So if it's the muscles of the neck, the head will sag. If it's the legs, the person falls down. Somebody is falling, yeah. Then all these are epileptics. Okay? Look at this. That has started. See, that is atonic. Okay? When you check the brain waves, you see a particular epileptic pattern, the EE. The last one is myoclonic. You have brief shock-like contractions. Okay? There's one in the small baby. That's sudden contraction, indicative of some challenges, primary challenges. So just to give you an idea of what the seizure types are. So let's look at the medications that are available. Before you ask questions. Okay.
I was just wondering, the absence one, is it the same as when children present absent-mindedness?
No. Absent, that one, daydreaming, those ones may be normal. They are not seizures. But for this one, when you look at the brain waves, find abnormalities, brain waves. There is something called NEAD, N-E-A-D, non-epileptic attack disorder. Some people under intense stress, psychological pressure can develop some seizure, psychogenic. When you check the brain waves, you see any abnormality. So they are not epileptics. Okay? So they can have a problem, like it might happen once, twice, but it's not necessarily epileptic stuff. Eventually, it just stops. Okay? Then, aside that, too, we can talk about non-epileptic seizures in general. You can have a seizure secondary to something, hypoglycemia, lack of oxygen in the brain, electrolyte imbalances. You can have some head injury, accident or something, have a seizure, cerebral malaria, meningitis, all these can produce. Okay? But it doesn't make you epileptic unless you begin to have repeated, you have the tendency to have additional ones in the, then you can be declared epileptic. Okay? Right.
I want to find out whether they are able at that stage, whether they are able to appreciate pain. Because in some occasion you hear them scream before.
Yes.
Is there an appreciation of pain?
The vocal muscles. That is why there's a loud cry.
So at that point, they are not able to appreciate any level of pain.
There is loss of awareness, loss of consciousness. So pain, any sensation, they are not aware of what is happening around. Right. So any other question?
Yes. The EEG,
Yes.
does it pick the signals during the seizure, or after the seizure, it can still pick?
You only see the abnormality when the seizure is occurring. So if it is very necessary for the ECG, you have to keep the patient on the ward monitor, or if you have the ambulatory EEG, then you fix it on the person. The person goes, counts. If there is a seizure, then he captures the EEG, then you can retrieve. Okay, right.
Okay. Please, I wanted to find out sudden loss of consciousness and person falls, and in a matter of seconds gets up. Is it also a form of yes?
It might or might not be. Okay, it might. It can be a seizure. It can also be some other loss of oxygen, something to brain brief. Then the person is back, like regular fainting. If fainting is not, oxygen is not going to the, that's down for a while. If oxygen, so the person recover, kind of. They are not seizure. So in a seizure, we are saying that there is an abnormality, the neurons of the brain. Okay? They become hyper excitable. There are two things that happen. They discharge repetitively. So a neuron, after discharging once, normally should be inhibited from discharging again. That's a normal thing. But somehow, that inhibition is lost. So they discharge repeatedly. Then the second one is that the discharge is hypersynchronous. That's the other big word. When one neuron is discharging, it carries a host of other neurons with it. So naturally expect only some small area to be sending impulses at it. Now you see that the whole place charging together in synchrony. It's an abnormality that shouldn't happen normally in the brain. Okay. So these two things are the key features of a seizure, and the research has established that these things occur when there is an imbalance between the level of excitation that is important for impulse transmission in the brain, then the level of inhibition that is supposed to keep a check on that excitation. So it can be both ways. If you have too much excitation, then there will be a problem. If you have reduced inhibition, it can be a problem. And so the drugs that are used to treat this condition can affect the seizure from those two ends. You can give drugs that to suppress excitation. You can give drugs that to enhance the inhibition. So those are the two broad categories of drugs that we'll be talking about. So some general points here about the use of drugs to treat seizures, epilepsy. Your goal is either to prevent, or if that is difficult, to reduce the frequency severity of. This can be successfully achieved in 75% of patients. The rest will need some alternative therapies. Okay? There is neurosurgery. If the thing is focal, if there is a mass somewhere in the brain that is causing, surgery can be done to remove. Okay? There is vagus stimulation. It's a recent technology where the stimulation of the vagus nerve can suppress seizures. That's also an option. Then diet. They have found that a diet that is very high in fats, low in carbohydrate, and the proteins would normally increase the production of ketones in plasma. So that diet is called a ketogenic diet. They have found, somebody found by chance that that ketogenic diet can suppress the manifestation. So that is also an option. Okay, so ketogenic diet, yes. So a diet that is high fats, low in carbohydrates, proteins. Okay? When you take that kind of diet for a while, your plasma becomes high on ketone. And so those ketones, some way, somehow, are able to suppress the seizure generation. The mechanism is not so clear, but works. Okay? So there are a number of them, modified Atkins diet and some other thing. are available for that. So the treatment most of the time has to be lifelong, which means that you have to think about the safety and tolerability of the medications. It's very important, including teratogenicity, one of the major challenges the use of anti-epileptic agents. And as Dr. Done was saying, monotherapy is preferred. You try as much as possible, use just one drug at a time until you have exhausted all your options. Before you can think about beginning to add because of the complications. Most of these drugs are either enzyme inducers or enzyme inhibitors. They are also bound to plasma proteins, so there are a whole lot of interactions that can occur. Yep. And they have also found that one of the major challenges for treatment, common reasons for treatment failure, is medication non-adherence. So as pharmacists, something that we have to look at seriously. Occasionally, the only way of checking these things is to monitor the plasma levels of the drugs. Here again, the availability of facilities to do come in again. And so policymakers, about some of these. So the drugs that are available should actually be called anti-seizure drugs. They are not really anti-epileptic. They are not disease modifying in epilepsy. They just prevent the seizure. So the condition will still remain. So appropriately, they should be called anti-seizure drugs. And not all of them are anticonvulsant in the technical use of the word. Okay, the drugs used to treat absence are not anticonvulsant. In absence, there is no convulsion. Are you following? So in the technical use of the word, we should rather be calling these drugs anti-seizure drugs. Okay, but we use this anticonvulsant, anti-epileptic, same thing. The challenge with these drugs when it comes to use is that we don't have a lot of quality studies to compare the efficacy, relative efficacy, maybe carbamazepine compared to that. Which one is more effective? You don't have a lot of studies because of the challenge in studying these agents. The trials that they normally conduct, because of ethical issues, start the trials by using the drugs as add-on instead of using them as therapy. Because of ethical issues, you can't deny somebody best medication by giving something you're not sure of. So it creates a lot of problems. So these are the anti-seizure drugs that are available. Before these drugs appeared on the scene, the most popular agent for seizures was potassium bromide. Potassium, that was a champion drug at that time. And the reason that potassium bromide was used was at that time they believed that epilepsy was due to excessive masturbation. And so if you can get a drug that to suppress the sex drive, which potassium bromide is known to do, then, your epilepsy can be suppressed. They were using this on a wrong understanding of what is there. But because bromide was a depressant, it worked. Not because of the sex drive issues, but because of its depressive effect on neurons. So from the bromide era, the major breakthrough was phenobarbital. Okay, or Americans prefer phenobarbital. So by 1912, this organic molecule was synthesized, and that brought a very significant change in how seizures were treated. But phenobarbital is very sedative as a barbiturate. So phenytoin, they managed to synthesize phenytoin. It was less sedative, and that was a major breakthrough. Primidone was also found as a prodrug of phenobarbital. So when you take primidone, it metabolizes to the active form phenobarbital. okay, and another compound, a very long name, also active. Then etosuximide came for absence seizures. Before then, they were using trimethadione, okay, but it has a lot of problems. So etosuximide was a very significant discovery. Then carbamazepine came, and then valproic acid also came. Now, it will interest you to know that valproic acid was also discovered by chance when somebody was testing another anti-epileptic agent in lab animals, okay, the preclinical studies. The substance he was testing was soluble in valproic acid. Valproic acid was the solvent that he was using to dissolve the drug. But then he found that then his control substance, control solvent, was anti-convulsant when he saw the results. Yeah, so that was the beginning. This one. So serendipity is key in CNS pharmacology. Okay. So these ones came later, felbamate, all these other agents came. And last 2 years, brivaracetam, a friend of levetiracetam, also in the US. So all these agents can be divided into about 4 main groups, depending on their main mechanism of action. Okay? So we have drugs that enhance the actions of GABA, because you remember GABA is in. So in seizures, you have too much excitation or reduced. So drugs that enhance the actions of GABA can enhance the inhibition. Okay. Then we have sodium channel inhibitors. Sodium is important for the generation of nerve impulses. So excitation depends on sodium ion channel function. So if you use drugs to block the sodium ion channel, you are also going to reduce. Then calcium ion channel blockade. There are 2 main calcium ion channel types when it comes to epilepsy, those that are important in epilepsy. The absence seizure we spoke about occurs because when they look at the excitation and the explanation for the disturbance is that some way, somehow, the area called the thalamus, which normally takes pulses from the rest of the body to the cortex, all of a sudden begins to send impulses to the cortex, unwarranted. Then the cortex will pass the impulse back to it, send it back, it will pass it on. And so there's a cycle of excitation back and forth between the cortex and the thalamus. Interestingly, that thing occurs normally when you are asleep. It's not supposed to occur when you are awake. When you are asleep, these things occur, okay? It has its function. But somehow, when the person is awake, this thing begins to happen. So it's more or less, you see the child as if he's sleeping off. Get the point, okay? So the passing on of the excitation from the thalamus to the cortex depends on a calcium ion channel called the T-type calcium ion channel. Without the T-type calcium ion channel, the thalamus is not able to throw that excitation to the cortex. So any drug that will be effective against absence seizure should be a T-type calcium ion channel inhibitor. Are you following? Are you following? The absence seizure depends on the actions of type calcium ion channels. So all anti-absence agents are inhibitors of T-type calcium ion channels. That's the point I'm making. So etosuximide and valproate have T-type calcium channel inhibitory property. That is why they are effective. Then we also have another group of calcium ion channels that are important for the release of neurotransmitters. What I showed you yesterday when we were talking about the monoamine things, you see that when an impulse arrives, then the neurotransmitter is released, then it binds to receptors. When the impulse arrives, what happens at the molecular level first is that calcium ion channels open for calcium to enter that side of the neuron. It is the calcium entry that lets the transmitter out. So when you also block those calcium ion channels, you can reduce transmitter release. In this case, the release of excitatory neurotransmitter. Okay, and the most popular excitatory transmitter in the brain is glutamate. Glutamate is what does all the transmissions. It's released and then it promotes the impulse transmission. So pregabalin and gabapentin are inhibitors of that calcium ion channel. Are you following? If you see GABA in their name, you may be tempted that they are GABA enhancers. Their effect on GABA is not so much. They were actually synthesized as a means of delivering GABA into the brain. That was the initial idea. That is why the GABA is in there. But when they tried them, even though they worked, they were not affecting GABA. They were rather interested in calcium ion channels. Okay? So gabapentin and pregabalin are inhibitors of high voltage calcium ion channels. Then the next group are drugs that inhibit the actions of glutamate. Glutamate is the main excitatory transmitter. So if we say there is excessive excitation, it means glutamate is abnormally working. So if you suppress its release or the receptors, then you can also reduce. So felbamate, pinamide, topiramate, perampanel are examples of agents that affect glutamate. Then lastly, there was one agent that enhanced the potassium ion function. If you open potassium ion channels in a neuron, there will be hyperpolarization. The neuron will be suppressed from sending impulses. Okay? So potassium channel openers, if they can get into the brain and affect the neuron, anti-seizure agent. So retigabin, also called ezogabin, was that drug. I think it had a lot of side effect issues. So I don't know whether they've recalled it or don't prescribe it so much. So I have said these things. Let's add a little here in the few slides, and we look at the individual agents of impact. So the GABA enhancers would work by suppressing the excitatory tendencies of the hyperexcitable neuron. So, as we said earlier, they would normally work by enhancing the actions of GABA. There are various ways of achieving that. He spoke about the mechanism of the benzodiazepines. They would affect the GABA A receptor, okay, allowing more chloride to enter the cell. They support the GABA to allow more chloride. That is what we said yesterday. Barbiturates to have the same mechanism. Okay? Just that the binding sites are different of the receptor. That's the main difference. There are other minor differences, but that is the main one. Then the anti-seizure drug vigabatrin works by inhibiting the enzyme that breaks down GABA. Just like a monoamine oxidase inhibitor inhibits monoamine oxidase that breaks down the monoamine, serotonin, noradrenaline, the same way. So it allows more GABA to be available to produce the inhibition. Then tiagabin. GABA is taken up just like the monoamines we saw yesterday. So GABA has a transporter that takes it up. So they were also able to synthesize a GABA transporter inhibitor, and that is called tiagabin. Okay? Mechanism of tiagabin is to prevent the reuptake of GABA, the presynaptic terminal, so that the levels will accumulate at the nerve end to affect the receptors to produce the inhibitor that you want. Then valproate, as you can see, has several mechanisms. If you saw the list here, find that it is here, three different places. So it is one of the few agents, together with lamotrigine, that are affecting in virtually all seizures. They are broad spectrum. Every seizure at all, they work against it because they have multiple mechanisms. So valproate here inhibits the same enzyme that breaks down GABA. Some other enzymes too, which are also important in breaking GABA. Then stiripentol. Stiripentol behaves like the barbiturate, prolonging the actions of GABA at the GABA-A receptor. Then the sodium ion channel inhibitors. Phenytoin is there. That is its primary mechanism. Carbamazepine, that is its primary mechanism. Lamotrigine, part of its mechanism. Valproate part. Pyramid part. Zonisamide, primary mechanism. So these drugs will block sodium ion channels, the neurons, using the excitability, making it difficult for the neuron to fire. The calcium ion thing I said, so two groups, the T-type ones for absence, succinimide, valproate, and the benzodiazepine clonazepam. Clonazepam has an additional effect on T-type calcium ion channels. Okay? Even though it's primarily a benzodiazepine, enhancing GABA, it also has type calcium. Pregabalin, fentanyl, lamotrigine also affect the other calcium ion channels. Then inhibitors of glutamate, parampanel affects a glutamate receptor called the AMPA receptor. Verbamate, NMDA receptor, all these are glutamate receptors. Dynamite also affects the metabotropic glutamate receptor type 5. Pyramate, AMPA. And then lamotrigine prevents the release of glutamate at the nerve terminal. Okay? That's a way of preventing transmitter glutamate. So all this use excitation. Okay? Good. So these are the indications. The main seizure classes and the drugs that are effective in those epileptics. So start with generalized tonic-clonic, and the ones in bold are effective with little side effects. The ones in red are effective, probably even more effective than those in bold, but a lot of adverse effects. And then the rest down there, not much information, not much studies, them to compare whether they are better or that kind of thing. They are down there. Now I have numbered some. That is from our new treatment guideline. The ones that we think are important are the ones that I have numbered there. That on top of our list is phenytoin. We don't care so much of the side effects. So long as it's cheap, we can continue to buy. I think that seems to be our priority more than other things. So phenytoin is there first. Phenobarbital is there. Carbamazepine, valproate, levetiracetam. The mechanism of levetiracetam is that it prevents the transmitter release by preventing the vesicle, what contains the transmitter, it prevents it from getting pushed out of the neuron, the transmitter. Okay? Focal, carbamazepine, number one, I agree with the international community. Oxcarbazepine, a friend of carbamazepine, they have similar mechanism, a slight variation, side effect. Levetiracetam, valproic acid, lamotrigine, all these are effective. Nobarbital, primidone, phenytoin, all the agents down there. Now, typical absence can be subdivided into typical or atypical. What I have shown you is typical absence. Occasionally, what I have shown you can be accompanied by motor manifestations. muscle twitching here and there, and that kind of thing. So that is called atypical absence. Atypical absence, myoclonic and atonic seizures tend to respond to similar agents. That is why they are one. So typical etosuximide, valproate, clonazepam if the patient can tolerate the adverse effects, and then lamotrigine and topiramate. And then you have the other ones there for collapse. Now, pharmacokinetics. I have already made this point. The anti-seizure agents have a lot of effect on liver enzymes. Phenobarbital, phenytoin, primidone, carbamazepine are inducers of that enzyme. So combination therapy can create problems. If you add it to another agent, they might enhance the metabolism of that other agent. And here you have to also begin to think about oral contraceptives, okay, hormonal contraceptives. So your anti-seizure agents, some of them are teratogenic. So when you put the patient on it, you want to prevent pregnancy. If there should be pregnancy, it has to be planned and be discussed with the neurologist. Okay, you don't just get pregnant when you are on the drug. Okay, so because of that, they might want to be on oral contraceptives. Now, some of your anti-epileptic drugs can enhance the metabolism of this thing, so they will still get pregnant. And then your drug is teratogenic, so it creates more complications. Okay? So that is why the combination therapy should be the last. So you try one drug at a time. If it doesn't work, try something. Valproate is an inhibitor. So it will enhance the effect of whatever drug you add it to. Typically, it works well with lamotrigine. They tend to combine them. But if you are going to add lamotrigine to it, the dose of lamotrigine has to be reduced by almost about half, because the valproate would potentiate this effect. Plasma protein binding is also an issue with phenytoin and valproate and the rest. Then for phenytoin, because it is one of our popular agents, what we have to know about its metabolism is that after a few doses, the capacity of the liver to metabolize phenytoin becomes limited. Its peak is reached. So subsequent doses can produce very drastic changes in the level of the plasma concentration. That's the problem with phenytoin. Okay? So the implication is that then the brand that the patient is using becomes very critical. If the clinician starts the patient on brand A, and then it gets finished, he or she comes to your pharmacy, you give brand B because of bioequivalence issue. If the new agent you are given is more available, that slight change in the additional increase that you are bringing can push the drug out of the therapeutic, very toxic levels. So in the BNF, you will find that they have categorized the anti-epileptic agents into 3 groups. The ones that you should be very careful about if you want to see the dose. Group 1, phenytoin, phenobarbital, carbamazepine, and others. Then group 2, the one that you have to use your own judgment. And then the group 3 that not a big deal, okay, when you switch brands. So let's have a look at those ones from the BNF. So a few of the popular agents, and then we end. Carbamazepine first, very popular for partial or focal generalized seizures. I've spoken about its ability to induce liver enzymes. So it can induce the liver enzymes to the extent that it can enhance its own elimination from the system. So its half-life can continually decrease on repeated doses. So occasionally, therapeutic drug monitoring will be very important. Know the correct levels. And so if you are adding it also to other agents, you have to be very careful. The adverse effects are tolerable. They are not so bad, because that is why it is popular. Dizziness, diplopia, the double vision. Things will double in your, but whatever you are seeing turns into nausea, gait instability, ataxia, drowsiness, and all that. One of the important those related adverse effects is water intoxication. When you take carbamazepine for a while, increases the actions of ADA. So it retains water in the system, doesn't allow water to go. So in fact, there is also a use of carbamazepine, syndrome of inappropriate ADA. So the implication is that when you use carbamazepine for a time, because of the water retention, sodium levels go down secondary to the increase in water volume. Are you following? So secondary hyponatremia. You have to be aware of that. And then the non-dose related adverse effects, bone marrow suppression leading to neutropenia, just that it is rare. It's not something you see frequently. Then hypersensitivity reactions. This one, it doesn't apply only to carbamazepine. It applies to what are called aromatic anti-seizure drugs, including phenytoin, tobarbitone, and carbamazepine. Okay? Now, some of their metabolites will provoke, hypersensitivity reactions. And there are three key things that will happen. There will be fever, then there will be skin eruptions. So you see things like Stephen Johnson's and the friend toxic epidermal necrolysis is a close friend of Stephen Johnson's. So any of them can show. Then there is another rash called drug rash with eosinophilia and systemic symptoms. DRESS. So DRESS, SJS, and then TEN. They are close friends. They can happen together with that. Then the third one is that internal organs can occasionally get involved. You may have hepatitis, may have damage to the bone marrow and other places. So this can happen as a hypersensitivity reaction. So expect it when you are using drugs. It can happen to anybody. The estimation is about 1 in 3,000 or so. But you don't know who that one person, whether it's your first patient, you cannot tell. Now, fortunately, they have found that for Asians, particularly Han Chinese, they have found a particular gene that predicts this adverse effect. So in the US, for example, if you are from Southeast Asia, you have to do an in vitro testing for that allele, okay? Human lymphocyte and allele, I think 1502, something. They will test for that in there, then they will not put any of this aromatic. Try something other than that. Those symptoms are likely. Right. So oxcarbazepine and recently eslicarbazepine are friends of carbamazepine. Similar mechanism, but use adverse effects, use enzyme induction. Phenytoin. I have said a lot about it already. The therapeutic range, if you want to monitor, is between 10 to 20 micrograms per ml. There's a water-soluble form called phenytoin. Okay, if you have problems with phenytoin. Phenytoin is not water-soluble. It's by, I think, a mixture of ethanol and propylene glycol or so. Those substances can create problems. So the adverse effect, those related ones can be minimized by slow titration of the dose. Start from a very low dose and gradually increase. Okay? Some of these will be minimized. So nystagmus, where you have involuntary movement of the eyes, up and down or left or right. Diplopia, ataxia, vertigo. Vertigo is normally because the drug affects the vestibular system, the ears to the cerebellum. And those things happen. When the dose is so high, then sedation and confusion would appear, including exacerbation even of the seizures if the dose is too high. Okay? Because blockade of sodium ion channels, if it's too high, can also begin to do other things in the brain. Then, what people don't normally like about phenytoin, gum hyperplasia. See? So your mouth will be full eventually. Gum. There is proliferation of the gum because this thing stimulates collagen and some other things there. So gums become plenty. Aesthetic problems.
But why should we like? It's not people that do not like this. An unpleasant adverse effect.
Yes, it is. But in addition to the problems, is the anxiety of people looking at this and saying things.
And if it threatens you,
Yes.
you may trigger into.
So it is important. Important. In addition to that, exotism can be an issue. The face, coarsening of the face, okay, adding up to the look issues. And then on the long term, megaloblastic anemia, peripheral neuropathy, and then osteomalacia. So these ones can be minimized by adding folic acid and vitamin D. Okay, that can. The non-dose related rashes, the hypersensitivity things I spoke about are part. And teratogenicity. The anti-seizure drug with the highest risk of teratogenic effect, valproate. Okay, so that one should be avoided in as much as possible in women of childbearing age. Okay, as much as possible. Then after that, you also have a second level of risk, intermediate. Phenytoin belongs to that area. It's been linked to the formation of cleft palate. Okay? Children are born with cleft palate. Their parents were phenytoin. That link is there. Fetal hydantoin syndrome. Then IV use of phenytoin. There are two things that you should be concerned about. Cardiac toxicity if you infuse the phenytoin too rapidly. So a number of studies have found that if you infuse beyond 50 milligrams per minute, there will be arrhythmias and there will be hypotension. Okay? So our treatment guideline has taken a very safer level at 25 milligrams per minute. Okay? Because that will be safer for those heart disease, elderly. So that 20. Let's take note of that. Then also a very rare syndrome, but can occur, purple glove syndrome. You infuse the agent and the area that you put the needle, the area you set the line to, find that the place swells and purplish black. Very painful. Occasionally, the problem with it occasionally can progress to necrosis, which may eventually warrant amputation of. Okay? It is a rare occurrence, but if it happens, the clinicians claim that there is no specific study, but they claim that dry heat and warm compress can take care of it. That is if it will resolve. When you do that, it will, or you can manage the pain with bupivacaine and Petidate, but might not always work. Some develop complications that may warrant surgical. So valproate, either valproic acid or sodium valproate or combination the two, evaporate sodium. And so this can be used across board. It affects all seizures. So it is very useful if you have mixed seizures. The same person has absence as well as tonic-clonic. Most of the tonic-clonic agents will make absence worse. So it is useful that you pick a drug that can affect both, so that you don't aggravate one aspect of condition. Adverse effects: nausea, vomiting, hair loss, which from literature, the hair loss worries women a lot. So if you are putting them on Valproate, you have to explain that to them for them to accept it. Tremor, weight gain is also an issue. So that can lead to metabolic problems. Then the teratogenic effects of Valproate is the higher risk of having neural tube defects. The popular neural tube defect is spinal bifida. I have an image. During the development of the brain, in fact, the brain develops from neural tube. Okay? That neural tube had to form the spinal cord and some parts of the vertebrae. So the drug interferes with the development of the tube structures. So this is part of the spinal tissue that ideally should be within the spinal column, but it's bulging at the back there like that. Okay? So if you are not careful, this child will not survive. So, so there is some risk, but in all for teratogenicity, the risk that a woman on these drugs will not develop, a child will not be born with teratogenic effect more than 90%. The risk that they will not, more than 90%. So occasionally clinicians can close their eyes and ignore some of these risks because the epilepsy itself, as Dr. Donny, the risk, the baby. Okay, so it's only Valproate they are very afraid about. The other ones, just add folic acid and just hope that nothing happens. Etosucimide for absence. The adverse effects are tolerable. Most of them, even if you titrate from low dose, the GI distress, they have found that if you give one single high dose, the risk is higher than if you split it into smaller ones, about 2 times daily. That will mean effects. Lamotrigine is also broad spectrum. The adverse effects are not so many there, as you can see, quite tolerable. Phenobarbital, the CNS depressant. You can expect all this somnolence, coordination, all these are related to CNS depressant effect. Except for the depression that it can cause and be issue. Long-term too, osteomalacia, which require vitamin D, galoblastic anemia, require folic acid, hypersensitivity reaction, as I said, primidone, the prodrug, barbital. Benzodiazepine. They are normally used to treat prolonged acute status epilepticus. Okay? They are not normally used for long-term treatment of epilepsy, because except for clobazam and clonazepam. The reason is simple. Their effects, their sedation is pronounced, but likely going to sleep a lot if you take it. Number two, tolerance will develop in a few weeks, and you may have to be escalating the adverse effect. And then withdrawal, okay? The risk of abuse, withdrawal syndrome, when the person is stopping the agent. So diazepam, lorazepam, midazolam, they are effective for acute and status epilepticus. Clobazam for some epileptic syndromes, and then clonazepam for absence myoclonic. So the other agent indications are here. But you can look at them later. So I can talk about status epilepticus. Now, the definition for status epilepticus is a prolonged seizure. Formerly, the cap was at 30 minutes. Then they found that the 30 minutes is too long. You can't leave a seizure to go 30 minutes. So now the level is at 5. If the seizure goes 5 minutes, consider it status. Okay? There is always fighting between where to fix the time, but anything beyond 5 minutes, consider it status. And then the other, aside the seizure being prolonged, you can also have a seizure that stops less than 5 minutes, but the patient doesn't recover, and then another one starts. So repetitive episodes without complete recovery. That's also another element of it that is classified as status epilepticus. So we have two groups of status epilepticus. We have the status form of the convulsive seizures, tonic-clonic, tonic, clonic, myoclonic, and all that. They are convulsive. So fall under the convulsive status epilepticus or general convulsive status epilepticus. Absence and co fall under non-convulsive status epilepticus. So because of the muscle activity, the convulsive one, and the risk of metabolic disturbances, this particular one is very dangerous, so requires emergency attention, rapid treatment with IV medications. Because after a while, the metabolic disorganization can affect brain and cause permanent brain damage. Person. So this protocol is here. You find this, the BNF. It hasn't really changed much, except that previously it was diazepam that was preferred. Now it is lorazepam. So as soon as a patient appears at the emergency, a prolonged seizure, immediately you give IV lorazepam. Then hopefully the seizure should stop within 10 minutes. If it doesn't, repeat the same dose that you give. Then if it doesn't stop after 25 minutes from onset, okay, that will mean 5 minutes after the second repetition of the benzodiazepine. If nothing happens, then you can try phenytoin or the water-soluble version of it, phosphonitoin, or phenobarbital. Okay? If that doesn't also work after 45 minutes, then the final solution is the person in general anesthesia. That would be the last stop. Suppress the whole brain activity. So this can be done with thiopentone, dazolam, or propofol. Now, for facilities that are not close to proper health centers where these things can be done, and if the status occurs in the village, before they get the person to a facility, if there is a small clinic or CHIPS compound in the vicinity, they can give diazepam, rectal solution, not the suppository, rectal solution, or buccal midazolam. The risk for buccal midazolam is that if you give high volumes, there can be aspiration. So the maximum volume should just be about 1 ml, preferably 0.5. Split, if it's 1 ml, split it in 1/2 at one side between the gum and the other one. Be absorbed rapidly. Then, if the problem is not serious, stop. It's becoming popular because of the stigma with the rectal situation. Having to undress the patient and something down there can be a problem. The buccal one is becoming popular. Then you can have the case where in women with epilepsy, find that their seizures become severe or there are exacerbations within particular times in their menstrual cycle. So that class of epilepsy where the seizure exacerbation, is tied to some particular part of the menstrual cycle. It's what is called catamenial epilepsy. Okay? Catamenial epilepsy. The reason is simple. The problem is determined by the balance of progesterone and estrogen. Estrogen is pro-convulsant. Progesterone is anti-convulsant. So within the areas in the face where estrogen is so high, like just before mid-cycle, very ovulatory phase, the risk of seizure will be very high. Then just at the beginning of menstruation, some will also have exacerbation. The reason is that the level of progesterone drops all of a sudden. Withdrawal from the progesterone triggers. So what can you do? Intermittent benzodiazepine therapy. So in the vulnerable phase of the cycle, you give clobazam to support the anti-epileptic agent. That is all. Okay. Then some have also tried acetazolamide. There was some effect. Then there is also the possibility of giving progesterone when necessary, so hormonal therapies. Then one interesting thing for phenytoin. If a patient is on phenytoin and having catamenial seizures, it's very likely the result of a reduction in the plasma levels of the phenytoin. Now, they have found that the enzymes that metabolize phenytoin are the same enzymes that metabolize progesterone and estrogen. So, in the luteal phase, towards just before the menstruation starts, that range, because of the drop in the levels of these two hormones, the enzymes now do not have competing, say there's competition, phenytoin and the hormones for the same enzymes. Now the hormone level has dropped. The enzymes have more time now for the plasma level of the phenytoin, and that can lead to the exacerbation, not necessarily because of the hormone thing. So for phenytoin too, if there are catamenial issues, you can also look at the plasma levels and see whether they have not, that you can escalate the withdrawal. If you find that your patient after 5 years is seizure free and you want to stop the medication, can you? It is possible, but it is difficult, particularly with the barbiturate benzodiazepines. Those that affect calcium ion channels, they are a bit better. But it can be attempted after about 4 years, gradual reduction per month. Okay? Hopefully, there will not be any withdrawal issue. If you are not successful, patient would bounce back with severe seizure status epilepticus. For pregnancy and anti-seizure drugs, I have mentioned the issue of the hormonal contraception, that most of them can reduce or enhance the metabolism of these agents. The teratogenic risk, I have mentioned that, and the fact that anti-seizure drugs, those that induce liver enzymes, can reduce vitamin K in the newborn. So that is no longer a big deal now, because all newborns now take vitamin K. Finally, there is a study that has a meta-analysis that says that there is a very small increased risk associated with anti-epileptic. So explain this to them, so that if they begin to have suicide thoughts, then they report to the doctor and see what they can do about it before it becomes serious. And the issue of driving. When medication doses are being changed, or when there's withdrawal of anti-seizure agent, the patient should not drive. It will also be part of our counseling points. So these are other uses of anti-seizure drugs. So at this point,
Okay, so any questions?
Yes.
What an investigation of side effect of carbamazepine?
Okay.
Does it manifest in human of some?
Yeah, so we said water intoxication. So you can imagine that that be a manifestation. If the load is high, some will get pushed into the interstitial area. So you can see pedal reduce some of this. The patient might also gain some weight when you check.
Hello, Doc. Just a bit about the pharmacokinetics. You know, some drugs, especially some prodrugs, would have to be metabolized to active forms before they go to work.
Yeah.
How does it play out in terms of whether, I mean, the enzymes, whether they will be induced? How are they affected? What the inducers and then the inhibitors?
Yes. The first thing is that for an interaction to occur, the two drugs should be metabolized by the same enzyme. That's when you have to establish if cytochrome-6. The two drugs should be, occasionally they may be metabolized by different isoenzymes. Not a big deal. So if they are metabolized by the same isoenzyme, then that is where the problem starts. So for a prodrug, which will have to be converted to the active form, if you give it with another drug that is an enzyme inducer, then metabolism is enhanced, so you get more of the active product. If it is an inhibitor, then to prevent its metabolism, so the concentrations of the active agent you want will be low. Right.
Hello, please. I want to find out whether there are certain conditions or situations that actually triggers epileptic attack.
Yes, there are a number of them. From stress, stress is one, excessive worry, sleep or the opposite, lack of sleep, any of them can do that. Fever, drugs, the one that concerns us, a lot of drugs. Fluoxetine uses seizure threshold to be given to epileptics. We've spoken about clozapine, so promazine, so pentisol, theophylline. There's this other one, even penicillins. Penicillins too, at some particular dose, because they inhibit the GABA receptor at very high dose. It's also possible. Hyperventilation. For absent seizure, hyperventilation can trigger it. So in the assessment of absent seizure, the clinician can indicate the absence by through hyperventilation. So this flashing lights is also a trigger. If you have a seizure, disco light, different colors, that can trigger a seizure. There is a case like that in Japan, where children were watching a popular cartoon, Pac-Man or so. Final episode where there was an action between and the hero. And so in the final blast, when the hero attacked the villain in the final blast, the way they animated the scene, a lot of colors, red, green, the flashing, few seizures in a lot of children. The emergencies were flooded with kids. Somewhere around 95 or 90, I've forgotten the exact day. So because of that, there was a regulation on colors, the spectrum of colors, frequencies you can use in animation. There's a regulation. It came from that time. Okay, so flashing lights can also be. There are a few others. They have escaped me, but I think I've given you some.
I would add mefloquine.
Okay, mefloquine. Yes.
Madam,
Yes.
my comments for all of us, and as we have the honor to have the chief. Listening to the presentations the past 2 days, it's like consistently what has been coming across is unlike cardiovascular and diabetes, where because of affordability, and reimbursement. We've moved away from the use of medications that were being used to newer agents where safety matching efficacy. Consistently, it looks like in mental health, we are sticking to what is cheap because it's not reimbursed. And older drugs are still being, those are the fact that we have newer drugs with safety. Maybe if we all support them with advocacy support, that they can move away from the 1950 drugs. Agent.
Yes, that is a good point. And one thing we have also realized over the past few days, occasionally we need some particular infrastructure to be able to use some of the. They are good agents, but need supporting equipment, plasma monitoring, and all that. So, because we don't have those facilities, occasionally they don't want to those drugs in our lists because of the competition. But let's get the equipment and then get them in. I mean, just a matter of getting the labs and collaborating with them, and then they will help us so that we can start. There is no need why Comfort should take blood sample. I mean, it's very embarrassing.
Okay, Angela, you wanted to ask a
too.
question.
I mean, so let's look at these things. I mean, sorry for that.
Doc, good morning.
Yes.
Sorry, I'll just take us back before Charles spoke, following up on what Francisca asked and what you responded to about the flashing lights, actually. So it's always a concern for me when I'm driving in traffic at night and I see these security patrol vehicles with their blue and red flashing. I get really worried. I don't know if there's been any case where somebody suffered a seizure from lights like that. I don't know, but somehow, especially at night when it's dark and those lights are flashing, this is one of the first things that come to mind.
That come to your mind. I haven't heard any case like that, but I mean, it's possible that can have. I haven't heard any.
Tony, I beg you.
Yeah, thank you. Would you consider diet, genic diet, as an adjunct, the main therapy, given the fact that when all other things fail, when levels gotten to the maximum, want to add that. We also recommend it in adults because that suggests that it's only effective.
Yeah, in children. The problem is the tolerability, but it's very difficult to endure it. The problems with doses and all, it's very difficult. It's unpleasant, but children are able to endure it, kind of. Okay, and so that is why. And so yes, it can be an adjunct, but because it's unpleasant, then.
And given the adults have all these funny tastes, for kids, you can virtually control what they take.
Yeah, I mean, a bit of force. Right.
Okay, Paul. Paul Obin.
Yes. Doc, thank you very much for them. I want you to touch on the last point. When switching formulation. My area of practice, I've seen it, particular drug, hydroxy. Okay. When you switch formulation, problem with the eye.
Okay.
I don't know whether it occurs with all drugs or maybe a particular. Also, whether it's due to bioavailability or biosimilarity.
Yes, so it's bioavailability. So it is not just a problem with the drug. There are other drugs like, especially if the therapeutic window narrow, then it becomes a concern that the change, the availability can shift the concern outside of therapeutic. So in your case, what is happening? It is going below the least, the lower limit of the range. So this is an issue. So here again, the issue of bioequivalence. We have to study our products. We have to compare them. The ones that we want to use, there has to be attempts to some studies to compare them so that you know that if you are switching from A to B, you have to increase the dose by this amount or you have to decrease. I think we should get to that level. It is not easy though, but I mean, you have to get there. Even the bioequivalence studies that are done occasionally, they use young, exuberant individuals to do it. And so occasionally it can be tricky with the elderly and some of these other people when you even use the data from such studies. So I agree with you. We have to look at this. So what can we do? I mean, let's try and stick to brands. I think that is the simplest way. Let's stick to brands. So the brand that
Okay,
you
so
think
I've seen several mics on, but it can be one at a time. So Ike, your question.
Yes, Dr. thank you. In your earlier presentations, you mentioned you were doing or you had done some work with some local. I don't know if any yet with the.
Plenty. But last year I published another one. The herbalist had creation, had the brought it. So I supervised one. So effects of young channels, so some gigabyte. There's an animal model for status epilepticus. We used it effective. And so I have published it. As
How close is it
academics
to-
always do, once we publish, the most
Dr.
important
Wale, you
step
want to say
of
something
making it
about it?
available, the next level, we don't have funding to.
Oh, it's funding.
So we have done a lot. Pharmacology department, I can tell you more than 20 different things that we have tried in animal models, which were used to discover phenytoin and all these things. Same models. We have found activity, we have published our findings. But
it will be
how
interesting
do we
to
use
know.
that? So they are there. You can
many
just
of
go
them there.
online.
No, after the knowing,
After
how
the knowing.
close are we in like making it useful for?
Yes, I have explained the limitations. It means that FDA would demand some kind of clinical studies from you. You can use it there. The FDA madam is here. See, so, they will demand studies. You can't just start using these things.
She wants to make a comment. Thank you.
Yeah, that's very true. Currently, we are still trying to get guidelines to clinical trials in herbal medicine or tradition, which is quite difficult because it's so peculiar to our setting fully. And as we all know, per international standards, to be able to ascertain safety in animal models is very simple, but efficacy is a big issue. Probably in infectious disease, they'll be able to get something small, but for these other therapeutic indicators, quite a difficult task. And so we are working on it, and we'll see if probably some safety and case studies and research articles could also help in finalizing.
See, the interesting case here is that what we are doing is reverse pharmacology. The herbalists are giving these things people already. It is working for them. That is why they are using it. So we just go take these things and come and scientifically see whether we can confirm that in animals. So when we confirm, because already it is in use, it probably should not be so difficult. Making that transition. Okay, but
Thank you. Interesting discussion. Okay, Sharon, I think, you're okay now. I saw your mic on. Okay, from Poma.
I wanted to find out, no tetanus patients on the wards, usually their rooms are kept a bit dark compared to the other rooms, patients in the other room. Is it because of the light causing the triggering the seizures? You say that's the reason.
It could be. Mr. Anochi.
Thank you. Mine is on if there is treatment failure.
Yeah.
and you want to introduce another anti-seizure drug, how the withdrawal and then the introduction of the new one be done?
I think Dr. Donation will examples. Normally, if you are switching, then you start tapering this agent, and then you introduce the other one from a very low. As you are escalating once, you are reducing. That is what they do. But in the last lecture, you can do that so that give you some real life experience how that is.
Thank you very much. I will take
Okay.
policy perspective in terms of the earlier questions asked. One has to do with the mental health, call it psychotropics medicines. And we ensure information from the practitioners before they even appear in the essential medicines list. We hear about brands and the way they affect some of the pharmaceutical care things. Yeah. But sometimes it's difficult for decision making because there's no documentation. We don't have the information to take a decision on issues. And of course, in the market scenario, you cannot just stop somebody from bringing in a product. I'm sure FDA will be able to tell you that. Oh. But if they have information, we have documented our practices regarding some of these products, not only for psychotropics, but also for antihypertensives, as well as some of the analgesics, I'm told that, yes. So I would implore that as practitioners, wherever our practice takes us, let's ensure that documentation is part of the processes. Currently, for almost all health facilities, there are adverse events managers who are practitioners from our facilities reporting to FDA regarding these things. But if we don't have the information, we can just come and say, oh, this product does not work. But in the public policy space, you can't take a decision on hearsay. You need the evidence. And so I will urge that in going forward, mental health is a very neglected area. And let us try as much as possible to make a difference in these areas by documenting sending the information to appropriate quarters. Once it gets to FDA, FDA will write back to us because they have the mandate to look at all the quality issues, efficacy issues, and also whatever. Thank you very much.
Point well noted. So we take the last one, Dr. Aboji from.
Thank you, Doc. You made mention of the effect of carbamazepine on ADHD and its secondary effect on increased sodium concentration. Increased concentration in sodium.
No, decrease.
Decrease concentration.
Because the water level is high. So now there's a secondary drop.
Yes. So I wanted to find out, would the use of carbamazepine in heart failure patients?
Because of the fluid overload and some of this. That is an issue. I'm sure there will be an interaction, physiological interaction. I'm not so sure about that, but theoretically, there should be a physiological interaction. I don't know the relevance of that, so we have to find out. So when the next lecture comes, ask then if he has any.
And then secondly, the bioavailability issue with respect to phenytoin. This has to do with managerial, though. Procurement of phenytoin. And sometimes you may not be assured that the previous stock, you'll be able to get it at the next level. So I just wanted to bring it to the attention of all of us that when we are doing procurement, we should be mindful of this effect of phenytoin.
Okay, I would want to add that levetiracetam doesn't interact with a lot of medications.
That is true.
So now they are moving towards, instead of carbamazepine, using a lot of levetiracetam. The brand name is Keppra. And pharmacists are doing a lot, pushing for the newer, safer brands. But there's been an old practice. So changing prescribing pattern is difficult. So now they are targeting the young psychiatrists like Dr. Donet. As you see, Dr. Donet will easily put a patient on lithium. The older ones will say cost of labs, but so the change is there, it's coming. So if pharmacists now are involved, if you stock, there's another way. You stop stocking the old ones and you stock the safer, newer ones. And then when the doctors request, say, no, we don't have, this is what we have.
But you
And
have the newer one.
the other side with policy that you could negotiate with the companies and then they can bring their cost down. So that's the procurement. So they are pushing, but it's not easy. No prescribing patterns. Sometimes the newer ones get expired.
Thank you very much.
Right. A
Our
little
time
comment.
is,
A little comment. I think that very good strategy out there, but I think that increasingly, when you present evidence, when you interact with the clinicians, when they use it, when they get outcomes, that also influence change in practice. Because I have a little fear that you stock what you presume to be a newer and effective agent, and then a patient needs the medication is not available. For epilepsy, that could also trigger a very serious seizure by the time you go and get your preferred medicine. So we need to work together. We still need to work together.
Thank you very much. So all the presentations and are here, Dr. Dones, and I'll give them to Vanish.
Thank you very much. Shall we give him another round of applause? Dr. Bochi, well done. You've done a very wonderful job, for the past 3 days, and we appreciate. Okay, so we are trying to get Dr. Donet, to come up. So maybe you can take your snack whilst we get Dr. Donet to come for the final,
Hello, Doc.
Yes.
Y-
Dr.
You can
Abuti?
you can hear me, isn't it?
Yes, I
Okay.
can.
Okay. So the
I heard the last bit of your lecture.
okay, that is fine. I'm sure there will be a lot of questions.
Good morning, Dr. Dene.
Hey, good
How
morning.
how are you?
Look, tired.
You're tired. Wow. Okay. You don't look
Tired
like
and
it. You look
on.
very fresh and
Oh, really?
yeah.
I really need a whole day or two just to be in bed and sleep.
Right, right. But this is the
Because I think
final, the very final lap. So
yeah, I
they're
think,
having their usual snack and then they'll be back.
okay.
It's been a very wonderful 3 days. We are very grateful to you guys. And my people have a lot of questions for you. So maybe you
Well,
start with that one, before you. Um, okay, colleagues, Dr. Done is back. So if you are ready, you can please walk in with your beverage, if you don't mind, so we can finish this and then you can go away. Yes, those who haven't done the biometric registration and you still need it, they've set up, so you could just sneak in there and they will help you. I'll tell them. Okay. Normally, you are now allowed to bring food, so please be careful you don't spill any drink around. Okay? No spillage.
Hello? Hello?
Mr. Divine, Verdi Pharmacy. Somebody is outside looking for you. Divine.
Yeah, hello. Are they ready now?
So, just a few minutes. I see
Oh,
they're
no
having their
problem.
snack. Yes.
I'm even trying to
Okay.
upload some slides and
So just some 5 minutes, I think. Thank you.
Hello, please, good morning. Those of us who were not able to do the online registration, fortunately, the system will be activated from Monday. So instead of seeing the exams officer or writing our names, you can personally do it from Monday to Wednesday. And the link is what I've given. apps.knust.edu.gh/students. So you log in with your username and password, and you do next. You get to the registration page. You select all the courses. Your courses will be there for you. So you select register all courses. You save, and then you print. Thank you.
Thank you, Ima. Those admitted to 6th year, when you are registering, remember to register the course for oncology, hematology and oncology, and also GI. All right, hematology and oncology and GI. That would add up to your maximum credit. Those are 6-year courses, so you start with 6. Hematology and oncology, that's one course, and then gastrointestinal and parenteral nutrition, that's another course. You have to add those courses. Hello, Dr. Dene.
Hello, Dr. Webin.
Oh, thank you. You are there. So I think we would start with the questions. We'll kind of warm up if they have any questions from Dr. Abuchi's lecture, something that was not clear to them, practice-related questions. So any questions for Dr. Done before he starts talking about the management of epilepsy?
Hello?
Yeah, hello.
Yeah.
Good to see you all, and good morning.
Yes, it's Charles here, the tall one.
Ah, Charles.
I I want to know the place of carbamazepine, phenytoin in your practice vis-a-vis the newer agents with improved safety.
Number one, carbamazepine remains a very important drug, not only in the face of newer drugs, but it's called the wonder drug. It is very, very central to the management of epilepsy and mood disorders, and even in difficult to manage situations as an adjunct in some psychotic condition. So carbamazepine is really, really very important. It's still, even here, it is still highly depended on. Phenytoin, its use is gradually going down, but it is still used in selected cases. So as far as the value placed on the two in current practice, especially in Ghana, is carbamazepine ranks highest. But in our context, phenytoin is still used, especially in the periphery, because it's really cheap. And if all the anti-epileptics, the good ones, will run out, phenytoin hardly runs out. So it's still being used, even though it has some damage side. But like I said, in places like Confanoche, we've really, really, really gone very low. I don't think we even stock phenytoin, but we do rely on carbamazepine a lot.
Thank you very much, Dr. Dene.
Okay.
Yes, I mean that was a very good answer for me. Any other question? Yes, Nana.
Yeah, Doc. Mention was made that eugenic diet. That is diet in high fats and low carbohydrates and proteins. Suppresses seizures. I want to know whether you recommend diet as an important thing in management of seizures or prevention
No.
of seizures. As in diabetes,
The
diet is very
the big
important.
answer from me is no.
Okay.
The mainstay to the management of, in fact, the to abort seizures is to put the person on medication. That's the mainstay. But of course, there are certain things. So it's still the biopsychosocial. So you're going to still have the biological, the psychosocial management, and then you have the social. So we'll look at that. So the biological, still the AEDs, you can't replace them. But of course, choice of AEDs is key. So, for example, the choice will depend on the type of epilepsy syndrome you are dealing with, or the type of seizure syndrome, if you want me to say that. It also depends on the age group. Okay. And of course, in our setting, availability and affordability. All of these are key to the choice that you make. But this is peculiar to our situation and also peculiar to certain rural areas, even in developed countries. Now, your choice, let's look at the first one. If the person has an absence seizure type epilepsy, okay, what is a recommended medication for absence seizures? Can anybody help?
Toxicimide.
Yeah, that is true. But do we have a toxicimide routinely on our market?
I don't remember the last
If
time
you
I saw
write
it.
Don't have.
Yeah, if you prescribe this, it will take forever and the patient will not get it. So in our setting, what do we use for absence? What do you know that we use for absence?
Yes, Grace?
Yeah, Grace.
Valproate, clonazepam.
Valproate. Yeah, so that's it. We use valproate. Now, what will happen if you use carbamazepine? Grace. What happens to a patient suffering from absence when they are put on carbamazepine?
Listen, I've not had any practical experience, but maybe to trigger into generalized.
What type of seizure is absence?
No seizure, no motor involved.
Yes, of course, there is no motor involvement in absence. But what type in terms of yesterday's lecture is where would you put?
Focal.
Is it a focal seizure or is it generalized seizure or is
Focal,
it secondarily
focal.
generalized seizure?
Focal.
So you say
Focal.
Grace says focal. All those who agree with focal say aye.
Aye.
He couldn't hear. Your mic on, and we are doing a voice vote. So
Yes,
those
we are
who
doing a
agree
voice
say
vote.
aye.
Okay, okay. Those who say it's generalized, say aye.
Aye.
It looks like the focal people outnumber the generalized people. True or false?
What is the situation here?
True, that's true.
Okay, so it means I'm more focal. Now, out of those who say it is generalized, those who think or know that it is primary generalized, say aye.
Right.
Okay, and those who think it's secondary generalized, say aye.
Aye.
There is only one voice.
Okay, so it means that those who think that it is generalized more believe that it is primary generalized. I hope I'm correct.
Yes.
Yes.
Great. Okay, to disappoint you, those who say it is focal, you are wrong. Those who say it is generalized, you are correct.
So the minority have it.
Now,
Yes, we have it.
those of the generalized who said it is secondarily generalized, you are wrong. And those who said it is primary generalized, you are correct.
Can you see us from where you are, Dr. Dene?
I can see there's a small box on. I wish my side of the screen could see the class to the class alone, so I can see everybody. But it's so small.
Oh, okay, that
on
tiny
the
box
screen.
out there. Yeah. But at least it's
Yeah.
better than yesterday.
Yeah, it's
Okay.
So absence is a primary generalized seizure. Primary generalized seizure. And carbamazepine worsens absence seizures. It makes it worse. So even though carbamazepine is a good drug, it is not a good drug for absence. And that is one of the things that we need you to know, that you must know all the types of seizures and the kinds of drugs that works perfectly with them. And then in our situation, if those drugs are not available, what are the alternatives that can be used? And then you also have to know the drug-drug interaction that makes their use difficult or worsen their situation. Mind you, this also goes through the CYP metabolism. So it's very, very important to know these ones. So knowing the type of the classification, or whether it is focal or generalized, and if it is generalized, whether there is the primary generalized type or it's a secondary generalized type. All of these help you in the choice of drugs and your advice to your doctors that you work with. Very, very important. So in the management, you will have AEDs as number one. AEDs as number one. All right. So for example, absence seizures, there is complete loss of consciousness. There's complete loss of consciousness of the patient, but the patient does not fall. The patient does not fall. Who can tell me why? It's Martha there.
Martha is here.
Great. Martha, can you afford us some?
my thinking would be that it may not affect.
Oh, it does affect the
It
cortex.
does.
In fact,
Oh,
both
okay. I give
both
up.
cerebral. This is a primary generalized, mind you. This is a primary generalized seizure. So both cerebral hemispheres are completely and totally involved at the same time. Like I gave you the your house analogy yesterday. Um, that you have your lights, your doom so go off at one time, all right? Spontaneously, all go off at the same time. That's what happens in primary generalized. In secondary generalized, the focus starts from somewhere, starts from here, and then spread around the entire house. So your bedroom goes off, and then gradually all the other places will follow. So that is what happens in secondary generalized. In absence is primary generalized. Okay. So can you attempt again?
Clarify for me yesterday. The impression I got was much as it is primary general, the end effect that you see may be if it is affecting the cognitive part or if it is affecting motor part. So if it does not affect the motor part, then we don't expect to see falling.
What makes us fall?
The
It
loss
does
of
affect the motor part. It affects the entire brain. So the functions that subserve the I mean the all the whole of the brain would cease. But why don't we fall? When what doesn't the patient fall
I think that
in
falling
absence?
is a result of the clonic something that happens. The contractions of the muscles make the patient lose their gait.
Well, a good attempt, but not
Please, can I
entirely so.
try?
Yes.
I think the ictal phase is very short.
No, it doesn't matter. The person, there's complete loss of consciousness. So the person is not aware of what's happening to them. People with tonic-clonic, they fall and they lose, there's also loss of consciousness. In fact, the key, I told you that, and I insist you go and read. It looks like you didn't go and have a look at the classifications. In primary generalized, there is consciousness alteration or loss of consciousness. All right, there is consciousness, complete loss of consciousness in primary generalized. All right, there is another sub classification under focal. Under focal, so there are two types of focal. We have simple, and then we have complex. Now, in primary generalized, there's complete loss of consciousness, like in absence. Under focal, if it is simple, consciousness is preserved. So the person is fully aware of what is happening to them. If it is complex, consciousness is altered. It means that the person does not completely lose their consciousness. So they are in between full consciousness and full loss of consciousness. So they are in between there. Depending on the severity, they may go towards one end or the other. So they are in between, it's impaired or altered. So either altered or we say it is impaired. Now, what keeps you standing is not necessarily your motor function, but what? What keeps you standing upright and not falling? If you understand the function of the brain that keeps you standing, then you would be able to answer the question on the absence. Because the same answer. All right. There is a function called posture. There's posture. And within posture, we have what we call visuospatial orientation. All of these are under the big umbrella of coordination, motor coordination. Now, if this is intact, you won't fall. And the structures that observe posture, which is broadly encompassing visuospatial orientation and coordination, and motor coordination, are outside of the cerebral cortex. They are deep structures. They are deep cerebral structures in the brainstem. Okay, they are located within the brainstem, and in absence, that area is not usually affected. I hope you are getting me.
Yeah, with you.
Good. So that is why people with absence would not fall. And the fact that they don't fall does not mean they are conscious. They have lost their consciousness by virtue of the fact that the absence seizures is a primary generalized. So you must know that. Any questions up to now?
Any questions? They're enjoying it. Please go on.
Okay. So you need to know the various categorizations of the of seizures to understand what treatment to go on. I'll send some slides on it. They kind of general slides that could help you understand the fundamentals of these.
Very much appreciated, Hodine.
Right. So, what in management we're looking at investigating the seizures. So, investigations. Who knows the key investigative tool in seizure, in epilepsy?
Paul, you want to answer that?
If you get it correct, mark it down. When I come down, we have lunch at a destination of your choice.
I think the EEG. EEG. Oh.
Okay. So you say EEG. I'll put it somewhere here because it's not number one. It is true, there's the EEG, but what is the number one investigative tool for diagnosing seizures?
MRI.
Okay, I'll put MRI here, but it is still not number one.
Scan?
History.
I'll put CT scan.
Patient history.
Okay. So now after several attempts, you are giving me all the options. so the offer does not exist again.
Patient history.
History, correct. That's the number one.
The offer.
So
Offer remains.
Epilepsy
Hey,
is a
you are not the only
clinical
one who said it,
diagnosis.
My mic was on. I also say history.
Oh, really? So how many people said history?
Charles,
Okay,
Charles.
so we have a date.
The offer remains.
No worries. We have a date, the 5 of you. So epilepsy is a clinical diagnosis. None of these is definitive. EEG is positive in 50% of cases. MRI and CT scan in our context never really shows anything. They will only pick up organic lesions if that is the reason why you are having the epilepsy.
Doc.
And what are some of the organic lesions? For example, tumor. And if it is a tumor that is causing the seizures, when you remove the tumor, the seizures should go away. Or it may show maybe venous malformations. It may show a focus, an infective focus, like cysticercosis. So it can show an infective focus, like cysticercosis, or it can show any space-occupying lesion. Any space-occupying lesion could be an abscess, it could be anything within the brain. So it will show. Or it can show, what we may now identify as epileptogenic lesions. And there are quite a number of them. But hardly would you find anything. Normally, CT scan MRIs will come back as normal. Of course, within our context in Ghana, we are not able to do the proper MRIs the way we should be able to do them so that we are able to get, good results on it. So what we say is that the MRI and CT scan, as we do it now, does not give a good yield for aiding in the diagnosis of epilepsy. Okay, it does not give a good yield. Now, normally, if the machine is primed well, you would request for it and say, do head MRI or CT scan with epilepsy protocol. If you say that the radiologists, they know how to retune the machine and so on and so forth so that it can give us some good yield. Now, in Ghana, we don't really have any of those machines capable of doing that. I think there's only there's only one radiologist who is able to do something with the machine to give us some data, but he's in Confanoche. He's the only one, but even that, still the machines are not primed for that. You need the particular software, you need some kind of reagents to pump into the patient and all of that to be able to do that, but we don't have them. So yes, investigation, the first investigation is your history. That gives you your diagnosis. And two things.
Can I
First
ask a question?
is, please go ahead.
About terminology, I want clarification. We ask about the major diagnostic, and then if you ask about investigative tool, I thought investigation meant the test and history.
Yeah, so it depends on the context that we are talking about.
But if you
All
use
right.
it as an exam, for instance, you ask us about major investigative.
want us to talk
Yeah.
about medical
If you
history.
wrote, if you wrote EEG, I won't punish you.
Thank you.
If you wrote EEG in that, I'll punish you. I do understand. But in an exam, I won't ask you that. I'll ask you, what is the major diagnostic tool?
Dr. Wabi.
And then you tell me, you would have to tell me that it is clinical history. Then I'll ask you
MCQs.
again.
MCQs.
Yes, I'll ask you again, what are the things you look out for? What are the key determinants within the history? And the first is there are questions that you ask the patients, and there are questions you ask an eyewitness.
Thank you.
Not somebody who was told what happened, though. Somebody who saw what happened or who has seen it happen a number of times. So in epilepsy, the patient's account, but more importantly, the eyewitness account, very, very key in your clinical diagnosis. EEG is used to monitor, to aid in diagnosis and also to monitor progress. But EEG, without EEG doesn't mean you cannot make a diagnosis. Without EEG doesn't mean you cannot monitor progress, because EEG gives you positive findings in 50% of the cases. So it means that another 50% of people with epilepsy would have EEG tell them that it is negative. Okay, that you won't find anything on EEG when you use that. Okay, so it is 50% correct, and 50% of the time it is not correct. Any questions?
So far, so good.
Do you have a question?
No, no. I was saying so far, so
So when it comes to the drug, in terms of treating, getting the seizures away, the mainstay of treatment is anticonvulsant drug. And the aim of treatment is to abolish the seizures. Aim. It is not just to control, but to abolish seizure or seizures. Now, it is when you are unable to, after adequate treatment, and you have not been able to achieve 0 seizures, then we fall on control. So even when the person is having 1 seizure, it is still unacceptable. But as we know, in reality, it could be very difficult getting. It takes a longer time. It needs you to achieve adequacy in the use of medication, rational use of medication. Now, again, monotherapy is the key. Monotherapy is the key. So key, push that one drug to its limit. If it doesn't work, switch, reduce. For example, if I'm using carbamazepine, I will push carbamazepine to the limit. And if I don't get any significant clinical results, I may replace it with, say, topiramate. And whilst I introduce topiramate from a low dose, I begin to reduce this one and begin to increase this one. So it becomes like I'm reducing this one and increasing this one. So there's a point that they meet, and then this one overtakes, and this one comes down. Then I take this one away, and then I continue to increase this to the maximum. whilst monitoring clinical response, and also repeating EEG in those, especially in those whose EEG became positive, because the EEG response would tell you if the drug is also becoming effective, and that is why you need to work closely with the doctor or with the neurologist or the neuropsychiatrist. So this is what you do, but in some situations you would need, as we learned yesterday, rational combination therapy. That is when, say, carbamazepine is doing well, and I've increased and increased, I've increased, and I've gotten to this point, but further increase does not make any significant change. So let's say the patient was having 4 seizures per month. Now the person has 1 per month. It means that carbamazepine is doing well, but I have reached here, and I still haven't reached there are 2 scenarios. I haven't reached maximum dose, but beyond this dose, I don't get any impact on the 1 per month. So what I will do is that I will introduce a second drug. Let's say I introduce lamotrigine after having studied its interaction with carbamazepine and found it to be synergistic or addictive, and also studying that lamotrigine can tackle the type of seizure disorder that I'm dealing with. So I start low and also increase whilst I maintain carbamazepine at that level. So I keep increasing until I get an impact on this one. So let's say whilst I added lamotrigine at this level, then I get 1 seizure per every 2 months, which is a significant improvement. I was getting 1 seizure per month at the height of a dose in carbamazepine. But beyond that dose, I wasn't getting any impact on the 1 seizure per month. When I added lamotrigine at this level, I was getting 1 seizure every 2 months. I still haven't achieved 0. So I'll push lamotrigine again. And then I get 1 seizure every 3 months. Good improvement. I push lamotrigine again. And then in the first scenario, I still haven't reached maximum dose, but I get to this point, and now for 6 months, 1 year, I don't get a seizure. And it means that this level of lamotrigine and that level of carbamazepine are adequate to give you 0 seizures. So that's scenario 1. Scenario 2, carbamazepine, I started with monotherapy. Carbamazepine. You can stop me anywhere because I don't know if you have any question, but you can stop me. Scenario 2, carbamazepine. I have increased carbamazepine to maximum dose. Seizures have moved from 4 a month to 1 a month, but carbamazepine has reached the maximum dose. It means that I cannot increase carbamazepine further, otherwise I'll get toxicity. So I introduce lamotrigine, the same phenomenon. And then I get 1 per every 2 months. I increase further, 1 per every 3 months. I increase further, and I get 1 per 6 months, every 6 months. Now I have reached maximum daily dose. So it means that both carbamazepine and lamotrigine, I cannot go beyond that limit. I now introduced a third drug, and then I achieve 0. So those 3 drugs would be the maintenance treatment for the patient. Or I increase lamotrigine, I increase I don't reach the toxic, the maximum daily dose. But when I got here, seizures became 0 for 6 months, no problem. For 1 year, no problem. And therefore, I can say amotregine and carbamazepine, you are heroes. So the person stays on these two at that dose as maintenance. I hope you are getting how the management, the drug management is going.
Very well.
Yes.
Great. So, rational choices of drug, know the type of seizure, know the medication that goes along with those types of seizure, know the age of your patient, and so on. Begin monotherapy. Push that mono drug to its logical limits in comparison with clinical response. When you do that, and let's say the monotherapy achieves 0 over 6 months, you maintain 1 year, you maintain 0 seizures. At that dose that you got to, you maintain the person on monotherapy and monitor. You can monitor clinically the two things. You should monitor clinical response and EEG. So EEG is 50-50. It helps you in 50% of the time. It doesn't help you in 50% of the time. So you must have this at the back of your mind.
Very good tips for practice and also for exam.
Yeah, exactly.
I have a question.
Yes.
I'm seeing that this combination, reduction, increases will require a lot of skill. Does it mean it's because there's nothing like a epi-epileptic dosing, like epi-analgesic dosing? That's why you have to do this.
Yes. That's why I say you should know the age, the age of your patient and their weight, because these are given according to weight as well. So you can have a 12-year-old who is weighing like a 40-year-old person, and you must adjust the dosing. So initially I said the age, but also the weight. Very, very important, because the dose must be commensurate to the body mass of the patient. Otherwise, you'll get suboptimal. Most of the times, and from my own experience, a lot of pharmacists just look at the age of the patient. I've had some of my pharmacists, Courage is there, they come to me, and that's one thing that the kind of bond I have with my pharmacists. Anywhere I have worked in Accra, Kumasi, wherever, they come to me and argue their point out with me. They will come and say, look, this patient, I don't think you need to put this patient on such a dose. Then I ask, okay, tell me, what are your reasons they put up? Now, one of the things that happens is that a lot of times the pharmacists have not seen the patient. They don't even know who the patient is. They are looking at the paper, the prescription, which is very good, but it just tells you about half of the story. If you are in doubt, look at the patient, compare. Then, if you are still in doubt, communicate with the doctor. So it's very important that both of us, clinicians, we are all clinicians, but the doctor and the pharmacist, you talk together, you share information, you agree on some of the things that is happening to the patient. Once you understand, and that is why it's important for you to know the biology, the pathophysiology, and understand it also, so that you can juggle it around with the clinician and make recommendations and suggestions. So there are times I have Courage or any of the people working with him who say, okay, but I am not comfortable with this drug. We have this other one that does so and so. Have you thought about it? And some of the times I haven't thought about that. But okay, a win-win situation. Let's give it a try. And through that, I learned also another way of doing the same thing that I've been. So it's important that we look at that as well. Then there are also a lot of the time that the pharmacist now understands my thinking. So when they see a prescription from me and they see something that another person would have said, oh, but this is outrageous. Though it's coming from me, it's duly signed, properly filled, they can actually explain to whoever that I did this because this patient that they are seeing, attending to, has so and so. And this first drug is maybe the principal drug. The second drug is used to ameliorate something that he's probably thinking about. So it's important that we understand some of these things. Otherwise, when we sit in isolation, the patient suffers. Now, we must know that some of the drugs are broad spectrum.
Before you proceed,
and
just
others.
one quick question for you, Charles.
Please,
Yeah, okay,
Yeah,
please.
assuming you have reached the maintenance dose, and what's your take on the issue about changing brand in the midst of whilst you are on a maintenance dose? There's been an
It is a
argument.
very change in brand. Technically, it shouldn't make a problem. But mind you, we are dealing with a human being. And this patient has been on, say, Tegretol, which is a brand name, and has achieved 0 seizures. Maintenance, very happy. There is no Tegretol, so I gave carbamazepine, which is a generic, to the patient. Yes, Tegretol contains the same carbamazepine. But this is from, I think, is it Novartis? Maybe right. PhD has made me to forget some of these.
You're very right. I think it's rather make you sharper the way I see it.
Well, I want to believe that. And then carbamazepine is coming from
Teva.
Somewhere in Asia. Okay, and we want to justify that it's the same molecule. Now, this patient has an emotional attachment to this. So, mind you, it's not only an emotional attachment, there's also cognitive. The moment you change and you don't get the fullest switch, physically you have switched to this one, it's the same thing, but emotionally and cognitively, this patient is still here. Now, we put the person on carbamazepine, barring all impurities that may be suspected here. Let's say that the purity here is the same here. The molecule sizes and everything parameters is the same. Let's even assume that Novartis is the same company that produced this one. All right, it produced carbamazepine, but not under the brand name Tegretol. And you say it is the same company. They still have cognitive and emotional attachment to the name Tegretol. Now this cognitive and emotional attachment would trigger, once they don't feel this will be the same as this, it will trigger an anxious response, as we learned yesterday. But this is not an anxiety disorder, it's a normal anxious response to prevent catastrophe. So once it does that, we have what we call the stress response. It's an alarm. So hypothalamus will go into mode high alert, and then stress hormones will be produced. Now, when these stress hormones pour into the system, what it does is that it leads to decrease. It does affect your immune response. So the immune resources are utilized, and there's a decrease. Once there's a decrease, seizure threshold comes down. Seizure threshold would drop, and once seizure threshold has dropped, somebody who was having 0 seizures on Tegretol, on carbamazepine, will start having seizures. Not because of has nothing to do with the dosing. The drug is good at that dose; they should have been seizure free. But because of this cascade of events, there's a drop in the seizure threshold. The person starts having seizures. So it's important. That is why there's a psychosocial aspect of your treatment to get the patient to buy into that. Of course, there are also other issues of, is it the same? Is it like having the same molecule strength? And this has to do with, manufacturing issues, which we know that we have problems with in our country. So that's the second bit. But the first thing that makes the patient, not respond to the switch, and therefore giving alternatives to your patient on the spur of the moment in the pharmacy and saying, I don't have this, but I have that. You must think about these things. Because once they trust their doctor and the doctor has written some drug, mind you, the doctor might have done some kind of education as well, especially if it's coming from someone like me. I would have discussed A to Z with the patient on it. So when he comes and he say, I don't have Tegretol, and even if it is Tegretol, I have courage will tell you, I prefer that to plain Tegretol. So you have this, and I have written that. Patient has bought into this emotionally and cognitively. You have that. The same company, the same drug. You give this to the patient would have seizures for the very reason that I've explained. So these are some of the things that come. So technically, no, it shouldn't happen, but it does happen because of this.
Doc, please, we don't do that. Right?
Yes.
I
Doctors
agree,
may
but
not do that, but he's talking from experience.
Yes,
I think
I'm talking from
policy-wise,
experience. I'm not saying that it is. No, I'm not also saying that it is wrong to
it is
give an
not wrong,
alternative.
yes.
I'm not saying that. It is right. You are helping the patient, but also know that these are the nitty-gritty. That's why before the alternative will be given, there is the need to do a back and forth with the patient and the patient's doctor. Patient's doctor buys into it. If the patient doctor buys into it, the patient would most often than not automatically also buy into it. You, the pharmacist, you win. The doctor wins. The patient as well.
Yeah, thank you very much, Dr. Dome. I'm Martha. I think
Yeah,
policy-wise,
Martha, yeah.
policy-wise, there is a generic substitution, but if
Yeah.
the doctor intends that a particular brand he's giving must be given, the rule of the thumb is underline it. Then the pharmacist is
Yeah.
aware that that is what you want. So I think that
Okay.
more education in this area will be very.
Yeah, I'm not even talking about generic substitution. I'm just giving you fundamentals to alternatives. So it may be a generic, all right? The drug you are substituting may itself be a generic, but you do not have that there. But there is an alternative that might not even be the same generic. Might be, for example, if I'm treating Tonicclonic and you don't have carbamazepine, but you have valproate, they are both generic, and they would both do fantastic job. But the doctor says the doctor has prescribed carbamazepine to the patient, and what is available is valproic acid or sodium valproate. So really, it's not only about generic substitution, but a general replacement with an equally good medication that will give you, and all things being equal, give you an equally good outcome.
Look.
Maybe, Dr. Dome, I'm sure
Yeah, Martha, yeah.
you did not get my drift. The drift is that there is a generic substitution, but if the prescriber desires that a particular product of choice is what he wants, knowing that there are generics that the pharmacy is obliged to give, depending on the discussion he or she might have had with the patient, it is policy-wise, we expect that prescriber, if he insists that it should be the very
must underline. No,
yes, it
I
must
understand
underline.
you.
So that is the drift, but it's not like
Martha, I understand you. But what I am focusing on, the focus on of this discussion is based on the patient, why the question in response to the first question that came, why would the patient not respond to drug A, to drug B, which was used to replace drug A, and it is the same characteristic as drug A? Is there a reason why that would happen? And I said yes. Technically, no, it shouldn't happen. The patient should respond to it. It's the same molecule. It's the same generic name. Patient should respond to it. But why is the patient not responding? There is the psychological factors of emotional attachment or emotional factors in response to the medication that the patient has been on, and cognitive appraisal of their medications. So that's what I'm talking about, not about the physician, insisting on a particular drug. This one, let's assume that the clinician is not insistent, but then the pharmacist, in the best judgment of the pharmacist, I don't have this, but I can replace with this one. Why would the patient not respond positively to that which has been replaced? Did the pharmacy do wrong? No, the pharmacy didn't do wrong in giving an alternative. No, but there is a gap that was not dealt with, and that is what I just explained.
I think it's very clear. It's a very important observation. I mean, the nature of this condition, I think that, and the attachment that the patient is giving to the product because of the outcomes, I think you are right on point. Yes.
Yeah. So it's always very, very, especially patients suffering from non-communicable diseases who are on long-term medications. It's the same principles underlie them. So that is why you look at the prescription and the patient in a biopsychosocial, with your biopsychosocial eye, always. So from after these lectures, please know that when you are dealing, it is not like antibiotics and things which are short-term. In long-term treatment of non-communicable diseases, know that it's a biopsychosocial approach. So we've talked about the biology, but in terms of the biology, in response to the very first question, there shouldn't be an adverse outcome. It should be the same. So no. But in terms of this, yes, the patient will respond negatively, or not will, but may respond negatively, depending on the standings of these two. Mind you, this is 2/3. This is 1/3. So 2 out of 3, definitely greater than 1 out of 3. So in the management of epilepsy, this aspect, this psychosocial, is so huge. And what I've talked about, the emotional attachment and the cognitive appraisal, is just half of the issues here. We will look at, as we are moving on, we'll look at a few others, and probably you'll understand the fullest picture. Yeah.
I have a comment. This is Kankam.
Oh, yeah, Mr. Kankam,
on the 2 examples you gave on the Tegretol, those are 2 different drugs. One is plain Tegretol, the other is Tegretol controlled release.
Yes.
So you cannot substitute them. You are not allowed to substitute them.
You are right.
2 different drugs.
You are right.
So
you are right. I'm talking about practical situations. The person does not have the CR, but we have the plain.
He shouldn't substitute.
Are you going to let the patient?
No,
are you going to let the patient go away?
The pharmacist.
Let the patients go.
The pharmacist should not substitute.
Can we have?
The pharmacist should not substitute a plain one with a controlled release. If you don't have it, then he should move to the next pharmacy. They might have it.
No, I'm not talking about private sector. I'm talking about public sector. The patient cannot afford the luxury of choice.
I hope Antimatter would agree with me.
If I can come in, practically, Tegretol CR costs in the range of 40 to 50 Ghana cedi.
But we are not interested in the cost.
No,
practical.
I think he's making a point. So maybe listen to.
In practice,
why
did you must find out why did the doctor choose the CR? It's because it gives that uniform plasma level
Concentration.
and concentration, and so you are get better result. The drops you don't get it. So it's a better form of the plane. So if the patient can't afford, you substitute, but you refer back to the doctor.
Thank you.
So it is
Exactly.
done. Yes.
Thank you.
So, but I want you to move beyond referring back to the doctor to communicating.
Okay, communicate.
Doctor, pharmacy, pharmacist. Communicate back and forth. I do that a lot. I even talk to pharmacists I've never met face to face. They call me, or I find a way of speaking to them, especially when I have concerns about specific concerns that might be misconstrued on my prescription. I talk directly to them. I seek advice. I discuss with them, and we come to a conclusion. Now, I agree the point that you cannot replace a plane with the CR. It means that you have to look for a control release version for replacement. I do agree, but we've had situations where all the control release versions are out of stock in the country. We don't have. Are we going to say that we will leave the patient drug free until we can get the control release? Something has to be done in the interim. And that is where you need the patient to buy, the patient and the patient doctor helping to get the emotional aspect and the cognitive aspect buy in, so that the person can be on that temporary remedy for maybe a week, two, whilst we will mobilize. So in management of epilepsy, the key thing is to go back to what is working, the exact one, which has worked for the patient. But in the meantime, there's a stopgap measure that you need to.
Yeah,
I think manage that stopgap
yes,
measure.
I think, Dr.
If you
Dene,
don't manage it well.
You've made this point.
Yeah, Dr. Boabe.
Yes, about the fourth time you're actually making this very important point. And if you look at the concept of pharmaceutical care, this is at the core of it. You know, the patient, clinician, pharmacists, working together to ensure that the patient get the best of the medication, monitor for optimal outcomes. I think it's very important, and we need to take note.
Very, very important. Very, very important point that I think that, and you people at the level of D and with your kind of experience and exposure and your status, you can make a huge, huge influence in this area. Otherwise, we continue to work in a very disjointed way. I've been in Confanoche for quite some bit, and I know what happens. I've been in various public hospitals, and I know what happens. It's an ugly sight. Pharmacist is saying this, doctor is saying that, and there is all kinds of words and things thrown about here and there.
And the patient is suffering.
So really, to what end can we go on this way? There has to be policy recommendations, especially Martha and the rest of you at the helm. There has to be incorporated policy things for doctors and pharmacists to work hand in hand. For example, in my department, I'm not only, I can only use there as an example. It's mandatory for the pharmacists to join the ward rounds and to tell us what is available, what is not available, what can be used, what cannot be used, so on and so forth. All of these are very, very important. The ward rounds, pharmacists are part. Case conferences, pharmacists are there to tell us. Sometimes we even ask the pharmacy, why is this drug not working the way we expect it to work? According to the literature, it should. So pharmacovigilance begins there. We give a reason, and the pharmacist is supposed to take that up and make sure that they find out why is this particular drug not working. If it's not working for a patient, most likely that it's not working for others that you prescribe, and maybe you've not captured it. But that particular one patient helps you to now investigate the rest. You go back to your catalog and see how many patients have been prescribed this. Then we now try to follow them up in the community through the various channels and systems that we have and be able to monitor their responses. That's the only way we can tell. Otherwise, we continue to lose patients to non-traditional outlets like prayer camps and
Thank you very much for the information. I've been telling them, but now it is coming from a very good clinician who is working with pharmacists in achieving outcomes. So I think very well noted. Can we move on, Dr. Dane?
Yes, we can. Yeah. Unless if there's no, I'm almost done so that we can have more discussions. So I've talked about the biology. I've talked about a bit about the cycle, the psychosocial aspect, the psychological aspect. Now the social aspects are the do's and don'ts. The social do's and don'ts. The do's and don'ts in epilepsy. Now, let's assume that somebody is epileptic in the class and out of no fault of his or her, let me use the more dramatic one, grand mal seizures or the tonic-clonic type seizure, which is the primary generalized seizure. The person falls, start to jerk, foams at the mouth, maybe pee on themselves, and so on and so forth, as the literature will tell you. The first thing to do is to prevent injury. In Ghana, the first thing to do is everybody runs away. But that is wrong. It's to prevent injury. How do you prevent injury? Now, in your setup, you make sure that the area around where the patient has fallen is cleared of, to be cleared of anything that could hurt the patient. Tables, chairs, sharp objects, things that in the course of the tonic-clonic movement, the patient could hurt themselves. Now, you don't need to do anything to this patient until the seizure stops. Usually, in 99.99%, the seizure will stop after a few minutes. Then you make sure to see that the cardiopulmonary activity has started. So once the seizure has stopped, check the pulse, place your back of your finger or try and go close with to the nose and see if the breathing has started. Shift the whatever, the dress or the shirt off and observe the abdominal movement with the breathing. Once you observe that, you're checking the pulse. The pulse means the blood is flowing and the patient has started breathing. That's what you do. And you make sure that once that is done, in a few minutes, the patient will gain consciousness. 3, you make sure you put the patient in the recovery or safety position. The reason that you don't know how long ago the patient ate, you don't know how what they took as food, and therefore the safety position is to place the patient on their left side. Normally, you place the patient like how you sleep on your bed on your left. Okay. Now, why do you place the patient on the left? The simple reason is this. If this is the human being, let's say this is your neck, this is your abdomen. Okay. So this is right side, this is left side. Now, your esophagus is here, and then it branches into your stomach and then comes this way. So we have our stomach this way. Now, your stomach is a sac with a tube entering here and a tube getting out of here. And the bigger sac is like that. So it is like a bean here. Now, if the person has ate a lot of things, is here, has drank a lot of fluids, is there. Now, if you put the patient on the left side, then this becomes like a calabash holding whatever is here. So the content cannot spill out or cannot spill back, because in an unconscious state, the sphincter or the door that closes here is not active. The brain is not able to, because everything has arrested. So this sphincter becomes loose and content can go back. But if the content is being held in this calabash-like shape or being shape, then it is there. But then if the patient goes onto the right side, then you've turned the calabash this way. So everything now, this place, there's space here, the contents are here. Now, this is the esophagus, and this door is open, is loose. So the content put pressure on this door, and the door opens because it's not locked, because the lock is fault. So the door is loose. The content would put pressure here, and you'll find content going back. And mind you, the esophagus and the airway are together like that. So the content comes, drips out, and goes in here. The patient aspirates and dies. So this is how people can die from an epileptic seizure, which is improperly managed. So the third point to do first is make sure the person is safe, clear the area. No need to hold and prevent the person from jerking, because that will not even stop the jerking. Clear the area, make the place safe. Anything that will hurt the patient, take away. 2, when they wait patiently, the seizure will stop. 3, make sure there's cardiopulmonary activity. 3, make sure that the patient is in a safety position after the seizures have stopped, and the patient is breathing and the cardiopulmonary activity is fine. So the safety position is called the left decubitus position, where you put the patient on their left hand, and then you bend, you straighten the what do you call it, the left leg, and bend the right on top of it in an L shape, right? So just like how you sleep on your left in bed, and you can support the patient at that time. You can support the patient so that they don't aspirate. So those are some of the things that you would need to know. Now, what are some of the don'ts? Because patients in types like the tonic-clonic, which we used to call grand mal seizures, people tend to say, okay, we will prevent them from biting their tongue, and they want to put an object in between the teeth at the time the patient is seizuring. When you don't do that, never put anything in the mouth of a patient who is having a seizure, because you can cause more harm than danger, more harm than good. Why? Because the muscles have gone into spasm, the teeth is clenched. You don't know what is in the mouth of the patient. When you are pushing that thing in, if there is an object in the mouth, that whatever you are using to push in between the teeth can push the object down the airway, and the patient can aspirate. Let's assume there is no object in the patient's mouth. Now, while struggling to push in, you can break a teeth, and that teeth can fall back and go into the wrong tube and cause problems. So you don't. If they are biting their tongue, they won't die from tongue biting. The tongue will heal. Let it be. So those are the do's and don'ts you need to. So, any questions up to now?
Yeah, Doc. Does that mean breathing ceases during this period?
During the ictal phase, breathing ceases.
So then
during the ictal phase, not all the types. No, I'm just using the grand mal as an example.
So
but
then
in grand mal,
there's a time the duration becomes important because breathing has stopped.
yeah, that is why people die from status epilepticus.
Okay.
Is one of the things, respiratory failure. And that is why status epilepticus is managed in the ICU, where they can be intubated. When there's respiratory failure, they can be put on the ventilator and so on.
So
that the machine will take up the breathing.
How can one help if this happens at home and the breathing has stopped? And here the patient is lying on the floor and you are waiting for
If the seizures have gone on for more than 4 minutes, you need immediately to call an ambulance. You need immediately to transport this patient to the nearest facility.
The ambulance calling is a problem. Is
I
there
know
something
our
we can
circumstances.
do, like CPR or something?
No, you can't do a CPR during the ictal phase. You can't.
So
do
then,
not do a CPR. What happens is that the functional respiration does not go off entirely like zero.
Okay.
There will be some a measure of it. But that is why the activity does not even go beyond 4 minutes. Or 5
my worry is because one time I walked in at home, my watchman opens the gate and his wife is lying down and she had a seizure. We of course took her to Confanoche, but I'm thinking in a situation where we cannot transport this person and we are just waiting for this seizure to come to an end. And here
in status epilepticus, you really have no choice but to get the person to a health facility, a good hospital in time. One of the things you can do in our situation you can't normally have it. If you have an oxygen cylinder at home, it's to put a mask over the nose and open the oxygen at a higher rate so that some of it will enter by passive diffusion. But in what you can do in a case of status epilepticus is really very limited. But for you as a pharmacist, one of the things you should do is to try and abort subsequent seizures. If you are good at administering a benzodiazepine, you can give short-acting benzodiazepine, all right, as parenteral. So that or by the anal route, okay, to help stop the subsequent one. You cannot stop the present one, but the one that is to come in the next few seconds, you are more likely to be able to stop it. But you must determine that it is a status epilepticus, and that is why it's important not to just rush into doing some of these things. If the person has repeated seizure attacks, first thing is to get the person to the hospital. But then the person may have recurrent seizures, but the intervals may be longer, like every 5 minutes they have. The person is not going to die because they recover their breathing within that 5 minutes. Okay, and that is where you can also be of help by giving the person a short-acting benzodiazepine, preferably parenteral or anal. But if the person becomes conscious in between time and there's adequate time, the person can swallow by themselves. Don't force it down. If the person becomes conscious and can swallow maybe oral, you give benzodiazepines to prevent the subsequent ones that are coming. And whilst you are doing that, you are transporting the patient to the nearest facility for a more substantive treatment. Any other question? Yes. Yes.
I have a question. Now, looking at the presentation, absence, is it possible that some children could have it by their parents? Then I would like to outreach on the possibility. Then again, can that develop into more serious effect on?
3 in 1.
I'll start with your third one. Absence is a serious one already. Absence is serious. Mind you, it is primary generalized. It is of the same level of seriousness as tonic-clonic seizure, or what we used to call grand mal. It's the same because both are primary generalized and both cause loss of consciousness. Both cause loss of. So the seriousness are the same. Can one lead to the other? Yes. You can have a mix of the two. Now, somebody having absence and not adequately treated, mind you, the area undercover, I told you that the deeper structures of the brain are spared in this. As time goes on, you'll find it spread to the deeper structures, and that is where you'll get the tonic-clonic coming in. So at that point, this patient has a mix of the two. It doesn't mean that one has become severer than the other. They have a mix of the two because these are in the same category. They have the same seriousness or severity. Okay. Now, in answer to your question, and in fairness to teachers, I can tell you that anecdotally, about 3/4 of all patients I've seen with absence seizures have come from the teachers making the recommendation. The parents didn't have a clue. Nearly, I mean, more than 3/4, because the kids I've seen with absence, the recommendations came from the teacher. The teacher realized that they stare blank in class, they stare blank, they keep not hearing what is said. They keep not hearing what is said or understand anything. And the reason is that absence tends to occur repeatedly, and you can get status epilepticus from that. Just that their breathing doesn't stop entirely, so they don't die. But they get it so frequently, as frequent intervals, that when you are talking, by the time you end your sentence, they've forgotten or they didn't hear what you said from the beginning. They only heard the last bit. So they ask you, what did you say? But when you begin to say it again, it starts happening again, and then they hear the last bit, they didn't hear your repeated, and teachers get frustrated. Those teachers who are not able to pick it up, they keep beating up the children or punishing them for not being serious. Then there is a dip in their academic performance. So a lot of times when you have a child whose academic performance is not picking up, one of the suspicions would be, is this child having seizures? Is this child actually conscious during class? Most of the time, they spend their time being unconscious. Okay. So in fairness, teachers have been the first point, and some of these teachers have found out that, oh, I have done everything possible to get this child to be serious, but I realize it is not the fault of the child. Then they start asking questions and trying to observe. Then they realize the child stares and becomes blank, and then they prompt the parent that, look, we think this need medical attention. So there are times the teachers accompany their parents to the hospital, or the parents come and tell me, this is what the teacher said to them. A few of the patients have said they have tried to observe what the teacher has told them, and they found the teacher was right. So absences, normally, first people to recognize are the teachers. And I do agree that more teacher education is very important. And I have in the past done some outreaches. In the early days, following my specialization, I moved to a lot of schools, had PTA meetings, did presentations, did some training. In the subsequent years, between 2014 and 2016, we actually did a survey of selected schools in the Kumasi Metro. And then we presented that outcome at the conference last 2 years in September 2016 at the Child and Adolescent Psychiatric Conference in Canada, somewhere in Canada. It was done by one of my residents who just passed out as a specialist, Dr. Kusi Mensah. And I sent him over to Ibadan under WHO sponsorship to do a sandwich master's in child and adolescent psychiatry. And now he's running the school health and the child and adolescent clinic in Pharmacy, and it's really, really good. So you can also latch onto it. Courage can do all the liaison with you.
Yes, I'm thinking, is it possible for people who are on medication or stabilized on anti-seizure medications, is it possible to still stimulate them to the highest intellectual level?
One thing is that the moment you stop the seizure, every episode of a seizure deprives the brain of oxygen for that period, that brief period. Now, that is why you need to reduce it to zero or to the barest minimum at the longest interval between. Otherwise, there is an additive, there's the damage from hypoxemia is additive. So eventually, little brain hypoxic injury become permanent big hypoxic injury, and it is irreversible. But in immediate sense, if you're able to stop all the seizures, what happens is that there is something called neuroplasticity of the brain cells, which we used to think that the brain cells did not repair themselves, but neuroplasticity is a phenomenon where brain cells they self-repair. And if you are able to do that, those little damages get repaired, and there is nothing affecting IQ and intelligence. So epilepsy does not directly affect IQ if you stop the seizure. But if you don't, then hypoxia or hypoxemic injury will now lead to permanent damage. And that is what you want to prevent. And that is where the social aspect comes in. People who have epilepsy and do not get resolution will lead to permanent brain damage from hypoxic injury. In Ghana, over 80% of the causes of our epilepsy comes from obstetric complications. So cases of prolonged labor, complications of obstructed labor, and so on and so forth. All of these will lead to the eventual development of epilepsy. Poor obstetric care and so on is a huge burden for us. Okay.
Look, Susan has a question for you. Susan.
Susan, yes.
Yes, good morning. Julius Caesar, he's supposed to be one of the most famous epileptics. But people have come up with some other theory that it wasn't epilepsy, but mini strokes. And one of the arguments is that because he started having this in his adult life, can you just get epilepsy in your adult life, or it has to start, like you said, it has to start from childhood?
Well, yes, you can get epilepsy in your adult life. Nobody can predict at what point it would manifest, but somehow the insult to the injury is always has been found to have begun a long time ago, most possibly from in utero. But never got manifested until a certain age. So yes, it is possible. And it does in our case, most of them, not most of them, quite a significant chunk of the patients we see never had any problems during childhood. Supposedly, they had a normal childhood, normal adolescence, and then in our adult life, they start having seizures. But when you trace back, most of the time, so that's why history is very, very important. And it's not just the information; there's a skill to be able to elicit the needed information, and you'll find out that there's something happening.
Yeah. Look, the last question from Mr. Kankam, and then Dr. Dune, if you can throw some more light on status epilepticus because of its emergency nature.
Could you tell us a bit more about the neuroplasticity? Some of us are getting
Well,
older.
the
Maybe
neuroplasticity
can
is
help
that
us.
it's just self repair. We found out that damaged neurons, parts of damaged neurons, they try to if this is the neuron, and then this part gets damaged, eventually you find that the function here gets transferred to another part of the neuron or another neuron, and the communication reestablished, or this part gets repaired and a new set of cells produced to take over from here. That's about neuroplasticity. It's just a self repair of brain cells.
Is there something
Okay.
we could do to help this happen?
No.
Like maybe some
It's just
diet or
no. At the moment, nothing. And in fact, it's still a subject of research because if we're able to find that's something you are asking me about, then a lot of diseases can be
Stroke.
resolved.
That's a nice one. So there were a lot of questions on status epilepticus for Dr. Abochi, and he deferred to you. That is why I want you to.
Okay. Which are some of the specific questions so that I can?
Well, I think that for the sake of our time, if you can go on and just,
Yeah, status epilepticus really is I've told you, is just a repetition or repetitive nature of what do you call it? The seizure. Okay, so you have two or more seizures occurring in succession. Fundamentally, that's what it means. Normally, after one episode of a seizure, that is it. If it happened in the morning or today, to take another 1 or 2 weeks or several days before another episode happens. That's the usual thing. But people who are suffering status epilepticus, they have a seizure within a few minutes or hours, they have another one, and then they can have like several of it in a day. And that means the person is having repetitive or recurrent seizures, that is status epilepticus. So by way of, explaining to you what it is, that's simply what it is. Apart from that, there's nothing really about it. There's a definition which says that if you have two or more than one seizure within a 24-hour period, some puts the definition within hours, and so on, then you have a status epileptic. But the very severe one is when the seizure doesn't abate or there's a diminished abolition, a brief abolition of the seizure, and then it recurs. So the person does not have the interictal phase prolonged. It's very, very short. And they do not have a post-ictal phase because they do not recover from the previous attack. Then another one starts, then another one starts, then another one starts. So that's what happens in status epileptic. Now, the management, mostly parenteral. So there's continuous infusion with anti-epileptics, and the use of benzodiazepines is very, very crucial because benzodiazepines are immediate acting. So short to intermediate acting benzodiazepines are very, very crucial in the management of, like midazolam, very, very important, like lorazepam in the parenteral form, very, very important in the management of status epilepticus. Now, also be mindful that benzodiazepines tend to depress respiration. So it is important that long-acting benzodiazepines are avoided as much as possible, unless we don't have anything, and that's the only thing we can use. But even that one has to be under very senior guidance from a specialist or a consultant. But most consultants will tell you that, and the book say, use short-acting benzodiazepines, midazolam, or intermediate-acting like clonazepam, lorazepam, in the infusion, continuous infusion. Then also use phenytoin is a drug of choice in status epilepticus because we have it in the parenteral form, and then it can be given in a very monitored way by machine and so on. Any more?
I think what you just said about the preference for short-acting benzo, and a little bit from the guideline that warning, which is the IV lorazepam.
Lorazepam is intermediate.
So
Unless
IV
I'm getting it wrong.
Or diazepam.
Yes, yeah. I said that you use short to medium term, short to intermediate acting, and I mentioned lorazepam. I mentioned lorazepam. I mentioned midazolam. Diazepam is long acting, and I said that you can use it, but you must be very careful about using diazepam in the sense that it is so long acting that it is heavy on what you call the respiratory depression. So it is very, very important that we take note of that aspect. Secondly, the metabolites from the drugs like diazepam tend to aggravate respiratory depression, unlike intermediate acting like lorazepam or clonazepam, or short acting like midazolam. So it is not in conflict at all. I'm saying that benzodiazepines can be used, but the preference short acting and long acting, because you're going to dose this patient frequently with benzodiazepines, and you are afraid of respiratory depression. And that's also one of the reasons they must be managed in an ICU in the event that you need to take over the respiration with the machine.
Yes, Doc. I wanted you to comment on epilepsy operation of machinery, and patients that are treated of medication type again.
That brings me to how long to treat. The recommendation is that if the patient has remained seizure-free for 5 or more years, you can wean them off medication whilst you monitor and see if something will happen or not. So you maybe from this month, you realize that that patient who has been on anti-epileptics for some time, from this month, you're monitoring for the next 5 years, no seizure. It is a good time to start considering weaning them off their medication. If it is poly combination therapy, you wean them off one drug at a time over a stipulated period whilst you monitor if there will be seizure. And then after you've completed the weaning off, you would also monitor over about 6 months to 1 year and see if without the medication they have seizure or not. If they don't, then that person is declared to have recovered or is well, and they can operate machinery. Now, operating of machinery like driving, if the patient is seizure free, in a lot of jurisdictions, they can drive. But if not, even if they have one seizure intermittently or even on occasion, then that person is not allowed. The key is that the person must remain seizure free, zero seizure. Okay. There are other things that can induce seizure, for example, starvation. So all of these come under the psychosocial management of the person with epilepsy, that they should not allow themselves to starve. 2, sleep deprivation. The person can be seizure free, but sleep deprivation would trigger what do you call it, a seizure. Then also, if they are, for example, using computers to aid them in whatever they are doing, or screens, the screen should not be flickering, because a flickering LED screen or other screens send light in pulses into the eye. So there's photo triggering, photo stimulation of the brain centers, and that can lead to seizure being triggered. The other things that mimic photo stimulation is where you are in an environment where there's like disco lights blinking up, blinking and flickering. So on the road or in environment where you have poorly lit, sometimes poorly lit, sometimes adequately lit, alternating frequently, it can trigger a seizure. They shouldn't be looking at moving objects that are rotating in a fixed gait. It can trigger. So if you are sitting in a car and you are looking outside and looking at the trees moving past you in that fashion, it can trigger. If you are looking at a fan, in the ceiling, moving up, going around in that fashion, you can trigger. If you spin suddenly on your feet, or like we tend to do, you spin and then you feel dizzy and you fall. That spinning can trigger a seizure. So the patient must be mindful how they turn themselves in their visuospatial environment, so that it's gradual, or it's purposeful, but not sudden. So these, and then, for example, you are doing a jogging in the wooded area, in between trees, and the morning ray of the sun that seems to be patches, where there is shade, there is sun ray, and you are running or you are moving at a faster rate, it behaves like flickering light, and that can cause a trigger of a seizure attack. So all of these things need to be made known to the patient, educated how to handle them, so on and so forth, and they may never have a seizure again in their life.
Right. Doc, I think I have 2 questions. The first one is, does noise have a role to play in triggering seizure? And work stress, and then last but not the least, I've seen
stress,
prescriptions that
work stress,
I've seen
tiredness.
Okay.
Tiredness, that's extreme tiredness. That's because these, as I've mentioned, they reduce the seizure threshold.
Okay. The next question is, I've seen prescriptions that has attain as part of the regimen, attain. And I want to know in your practice whether it has any...
Attain has no place in seizure management. Attain is an anticholinergic that is used to prevent side effects of antipsychotics or or drugs that inhibit the dopaminergic pathway, leading to extrapyramidal side effects or Parkinsonian syndrome. And therefore, it has no place in the management of seizures. So I don't know on what basis anyone will be adding attention to anti-seizure drugs.
Thank you.
Hear your response to the sound. He also asks about sound or noise. This is also one of the triggers.
Yeah, there have been some reports that excessive noise can get the brain to get. Mind you, this is action potential generation by the neuronal cells. So, but directly, no. But if the threshold of the sound is so bad, so much, yes, potentially it's possible, but not as a direct consequence.
Yes, Dr. Tonicclonic, quick one. Understand you could have non-convulsive. Is there anything like non-seizure convulsion?
If there is no seizure, there will not be a convulsion. I told you yesterday that convulsion is the manifestation of the seizure. Yeah. Now, convulsion has to do with motor activity.
So what I'm trying to drive at is, could you have manifestations of convulsion? Okay, not calling it convulsion, but without a seizure underlining it.
No, you need a seizure. Seizure is the unit of the manifestation. Without that unit, that fundamental action going on in the brain, you would never have a convulsion.
Thank you.
Yeah. So absence is a non-convulsive seizure.
Okay, please, I want to find out for a patient who has been taken off his or her anticonvulsant, and then that patient suffers an episode. In the reintroduction, do you go back to the maintenance dose, or you still have to start with a lower dose and titrate upwards?
Yeah. You start gradually again and then push up. They may not need the same maintenance dose as before, depends on the situation. So you would have to start again. But if the interval between the last safe maintenance dose before they were taken off and the recurrence is reasonably short, your best bet is go back to the last safe dose.
Tony?
So, and someone might ask, what is reasonably short? If it's anything up to 6 months or less, I will put you back on your last reasonably safe maintenance dose. But if it's a year and beyond, I'll start you from low and push you up. In between 6 months and a year, it's discretionary. It's actually patient specific, and you would want to make a clinical call on that. You may be right, you may be wrong.
Dr. Done, it's midday here, and people are still active. I still want to ask you some more questions, but I'll allow for only one question, and then you wind up on your presentation.
Oh, thank you very much.
All right, thank you. Please, in the management of status emergency, some literature suggests use of timing followed by dextrose, 50%. Please, what's your take on it?
Oh, of course. That could make some sense, in the sense that during the period where oxygen is seized, the brain activity goes down. One thing is that blood supply is cut during blood supply is not is diminished during a seizure. to that part of the brain or to the entire brain if the entire brain is involved in primary generalized. And mostly, status epilepticus is a primary general. The entire brain is involved. So you would need to supplement the energy needs of the brain so that the damage does not become overly massive. Now, why do you give timing? You give timing before the glucose to prevent with venicase and encephalopathy developing. Okay, so that's why you give the timing before you give glucose. Otherwise, it causes permanent damage to the deeper structures of the brain, and the patient might not recover from it. In fact, will not recover from it. Hello.
Yeah, Dr. Dene.
With you. Yes.
So, are you concluding?
Are you satisfied with the response?
Yes.
Okay. So it is really, I mean, it's most status epilepticus may be, abolished within reasonable time for the brain to recover and use its own natural resources for energy. But if it goes on and on, we've been people, a few instances we've had patients with status epilepticus who've gone on for days, maybe a week or more. That is when you would want to add some of these things, but it's not like right from the beginning you put time in and you start giving glucose. No.
Thank you very much, Dr. Dune. If there is one thing that you have succeeded in doing, you have succeeded in stimulating huge interest in mental health among the participants. And if you agree with me, if you want to applaud, and applaud very loud.
Thank you. Thank you. It's been a pleasure. It's been an honor meeting all of you.
So that speaks for itself. So well done.
Thank
I mean,
you.
3 days of very interesting and stimulating lectures, and we are very, very happy about it. If you ask me whether the objectives have been achieved, I would say yes, yes, yes. Thank you very much.
Thank you.
And I don't know if you want to say anything.
Yeah, I want to thank the class. I'm honored to be aiding in this program, and I'm thankful that you've accepted me to be able to share the little that I know in this area with you. Do more research. If you find anything that I didn't say, you can share it with me. I will learn. If what I think is the current knowledge is not so much what you'll find out there, reach back to me and let us discuss. And I would also learn from you as much as practicable.
Okay.
Thank you very much.
You may also send them some practice questions, that they can, whilst they are reading and revising, some practice questions that probably could be very helpful in their exam.
Yeah, sure.
And then some guidelines,
evidence-based
guidelines, to update, their knowledge in this area as well. Susan wants to give the vote of thanks. So.
Unfortunately, my side of the video is gone, so anyway, I'll listen anyway.
Dr. Bobby. All that. Want to know when we are getting his slides before.
Is it this one?
Yes.
Dr. Dine, is this slide amongst the information you gave to Dr. Abochi?
No, this particular one will come in the next couple of hours.
Okay, next couple of hours.
I just need to modify a few things.
Next couple of hours. Okay, Susan.
So, Dr. Dane, on behalf of the pioneering class of the Pharm D Top Up program of KNUSD, we want to say a big thank you. You have stayed up at the ungodly hours to teach us and to stimulate us. I'm sure we've all lost our anxiety about psychiatric medicine and therapy. I think that you've calmed us, you have taught us such a way that even without looking at your notes, scoring 100 when you.
Hey.
So we want to say thank you from the bottom of our hearts, and God bless you. We wish you all the best in your endeavors, and
Thank you.
we hope to see you because some of us you owe us lunch. So we hope.
Oh yes, I'll see you.
We hope to see
Don't
you
worry.
soon.
Track me down. Track me down sometime in September, and we will have lunch. That's a promise.
Excellent. So you did some therapy here as well? Well done.
Thank you very much.
Okay, so thank you very much, Dr. Donay.
Thank you, Caesar. Thank you.
Okay then.
Bye
Right.
bye.
Yeah, enjoy your day. A few announcements, please. Okay. Now, many people have been asking me about project, whether you're going to do project in this course. Project. Oh, no. I mean, but no, it's not out of place. Sorry, it's not out of place. It's a good question. It's a very, very important question. But the answer is that yes. Yes, you're going to. You're going to do a project, and we want to encourage you to start thinking about it now. That is why next month, the lecture is on research methods and biostatistics. So research methods and biostatistics, that is the subject for next month lecture, which will be held both in Accra and in Kumasi. The Accra caucus have announcement for the Accra people, so if you would also give them a few minutes. Your project is not going to be like the postgraduate project that will go to external, what do you call it, assessor. The projects are going to be handled by your supervisors. It's going to be handled by us, so, but it has to be a landmark project. Yes, it has to be a project that can be published. That's an admonition that I want to give you. And we also want to encourage all of you to do projects in your areas of practice. All of you to do projects in your areas of practice. I don't know if Dr. Anto want to say anything. Yeah. Doc, do you have anything to add? All right. Okay. So, yes, on that note, we'll allow the Accra people to give the announcement, and then I'll say, Jenny, you can do the online registration. They've given you the app and the link, and I think they will give you all the various references. Thank you.
Okay. Police, I'm talking on behalf of the Accra team. My name is Charles Fodio. I'm part of the organizing Accra meeting. So we are, as you heard, Accra will be hosting 2 days for the next session. Taking the feedback that you gave on the first one that we did, concerning patient quality, PA system, everything. So what we've done is that the next session is going to be 2 days. So we have done an actual costing. In reality, we see people who paid the last time for the next session. Looking, the only difference that will happen between what we did the last time and now, factoring in the lecturers that we are going to. And we are not paying for their accommodation, but we are supporting their transport within and Accra for the 2. And as Ghanaian Hospitality also encourages, one of the evenings, trying to hold that with the lecturers who lecture. And then also finding them or give a Ghanaian, in addition to the bills, PA, and every other costing item. As the last one, the amount we paid, the 100 Ghana we paid, was just enough what you saw the last time. So what we are proposing now is, because this one is a 2-day session, they are proposing that we pay 200 for 2 days, cover all these additional benefits that we need. So on the platform, we will be sending you mobile money number and the people that you can pay to, a deadline, so that we can start preparing for it. And unless there's any burning question, if there's any burning question, you can ask us on the platform or ask Antiama, Sulias, and Dennis, and then Pharm and the team. I think the accommodation is the UST is paying for the accommodation. We will just pick them to and fro. Okay, thank you so much for your attention. Talk again.
And safe journey.
Want to be in Accra. So if the southern sector pharmacists want to be in Accra, just let us know, because we are budgeting with that number. If
Southern sector, they will be in Kumasi.
Yes, and then southern sector will be
southern sector in Accra, sorry.
Yes, and the northern sector will be in Kumasi. Just in case you are southern sector and you don't want to come to Accra, please let us know, but we will be coordinating with you on the platform. Thank you. So we said,